Unfortunately, I'm taking the wrong topic at the wrong time. Post lunch, it's not as easy as presenting heart failure with reduced ejection fraction, which has a robust evidence. I'm not discrediting Dr. Chala, but that's the truth. You all know. So I'll be discussing heart failure with preserved ejection fraction in brief. And these are okay, thank you. So it was described by Dr. Sambata in the morning. Heart failure with preserved ejection fraction is diagnosed in a patient who has symptom signs of heart failure in the presence of normal or near normal ejection fraction. The prevalence is it's as common as heart failure with reduced ejection fraction because it constitutes 50% of patients with heart failure. But what makes it different is this group of patients are heterogeneous. They have multiple comorbidities usually, and the mechanism of heart failure, pathophysiologic alterations are heterogeneous. There is no clear, straightforward pathophysiologic mechanism described for heart failure with reduced ejection fraction that's duplicated in patients with preserved ejection fraction. And the therapeutic options are very much limited as well. So the underlying pathophysiologic mechanism is believed to be abnormal diastolic function in the presence of normal ejection fraction. But recent studies have shown that this majority of these patients also have systolic dysfunction. We say these patients have normal systolic function based only on ejection fraction. And as most of you know, ejection fraction is a poor surrogate marker of systolic function. In patients with preserved ejection fraction on whom strain imaging was performed, they were found to have significant systolic dysfunction as well. And the pathophysiologic alterations are not limited to the myocardium. It involves endothelium diffusely, and the skeletal muscle malfunction also is said to contribute to the pathophysiologic mechanism. But the presence of heart failure symptoms with normal ejection fraction doesn't qualify as heart failure with preserved ejection fraction in the absence of clinical evidence of symptom signs of heart failure. These are the common conditions. This was also described in the morning by Dr. Dejene and Dr. Sambata. These patients tend to have multiple comorbidities, which includes hypertension, arrhythmias, coronary artery disease. They tend to be more obese, diabetic with CKDs, and that makes it difficult in terms of approach to diagnosis and management as well. As most of you might have practiced, especially who practice internal medicine, we see patients who have complaints of dyspnea on exertion, and we send echocardiography. When echocardiography comes with a normal ejection fraction report, we just discard the diagnosis of heart failure. That's what I used to do, at least. I don't know about you. So this is a question from one of my patients, which I copied it verbatim. So as you can see, she said, እኔ ዝም ብሎ ድክም ይለኛል ልቤን ይደክመኛል ስላቸው ልጆቼ ደግሞ ልብሽ አይደለም ሐኪሙ እንደነገረን ከሆነ የልብ አልትራሳውንዱ ላይ የልብ ጉልበት በጣም ጥሩ ነው, which means ejection fraction is normal, ሳምባራጅም ኖርማል ነው, chest x-ray is normal, አንቺ ደግሞ እግርሽ አያብጥም, you don't have edema, so በዚህ ምክንያት ልብሽ ችግር የለበትም ይሉኛል. እኔ ግን አልተዋጠልኝም. እንዲያው በሽታዬን የሚያገኝልኝ ሌላ የተሻለ ምርመራ ይኖር ይሆን ብሎ ጠይቀውኛል. Anybody who would suggest an additional diagnosis for this mother? ምን እንዘዝላቸው የተሻለ ወይም ተጨማሪ? So that leads us to diagnosis of heart failure with preserved ejection fraction, which is really a challenge. As it was described by Dr. Sambata in the morning, the diagnosis of heart failure in general is mainly clinical, and biomarker studies and imaging studies are mainly supportive, either to confirm diagnosis, prognosticate, or decide on future management. There are certain scores which were proposed for diagnosis of heart failure with preserved ejection fraction by different societies, which we will see briefly. So as this was a group of patients who were included in the Paragon heart failure study, sacubitril valsartan, and the majority of patients with heart failure with preserved ejection fraction as dyspnea on exertion. As this mother claimed, edema occurred only in 45% of patients, less than half of the patients which were included in this study, which tells us that the absence of edema by itself cannot rule out presence of heart failure. The other more common symptom is fatigue, and the PND, jugular venous distension, and the likes, which we commonly see in patients with reduced ejection fraction, are not as common. These are diagnostic workup recommendations for every patient with heart failure. The same slide was projected in the morning, so I'm not going to repeat it in detail. And right heart catheterization is recommended in selected patients on whom we don't have an adequate evidence for diagnosis of heart failure with preserved ejection fraction. But one of the things we could do for the mother I described earlier is to order biomarkers, natriuretic peptides, which were described in the morning as well by Dr. Chala. But still, in an elevated, the BNP or NT-proBNP would support the diagnosis of heart failure with preserved ejection fraction, but it doesn't automatically rule it out. Still, elevation might follow just an unrelated cause, like patients with chronic kidney disease and patients with pulmonary hypertension are related to left-sided heart failure can have elevated BNP as well. Patients who tend to be obese, which is the commonest finding in patients with the heart failure with preserved ejection fraction, tend to have a low level of BNP and NT-proBNP. So we have to keep in mind these alterations whenever we use BNP or NT-proBNP for diagnosis of heart failure with preserved ejection fraction. But if it's elevated, it's highly suggestive of heart failure with preserved ejection fraction. It's said to have a specificity of as high as 85%. Echo is another tool. Maybe the mother I described earlier had echocardiography, but echocardiography is not only about ejection fractions. And we, as probably our colleagues in the Internal Medicine Society, whenever you see a report of echocardiography done by cardiologists, don't focus only on the conclusion or the ejection fraction alone. Try to explore other parameters included in the form of table or as part of description. But the presence of normal ejection fraction with just grade 1 diastolic dysfunction report doesn't mean that the patient has heart failure. This is just a stage 2 heart failure as described in the morning, but for heart failure with preserved ejection fraction to be diagnosed, there has to be definite clinical symptom and sign. So my recommendation is to explore our report. This is the commonest format used in the city by most centers. This is just an example of echocardiographic report format we use at St. Paul. I'm sure everybody practicing cardiology uses more or less similar reports. So what we include is we usually include dimensions as well as you can see on the right side, we describe diastolic alterations, including E to E prime ratio, E velocity. LA volume index is not commonly done, but if necessary, it can be included. And the conclusion part is just one of the reports. If you explore every part of the echo report, you can get a clue that can be helpful for scores used in the diagnosis of heart failure with preserved ejection. But this is one of the scores recommended by, excuse me, American Heart Association, American College of Cardiology. H2 stands for heavy and hypertension with a score of 3 total. F for atrial fibrillation, pulmonary hypertension, age above 60, and feeling pressure, which is described by elevated E to E prime ratio. A score, the higher the score, the higher the probability of heart failure with preserved ejection fraction. This is a score recommended by Heart Failure Association of European Society of Cardiology, which includes P, E, F1, and F2, where P stands for the initial workup, followed by diastolic workup, advanced, and etiologic workup. So if you can score this based on available data, you may easily be able to arrive at a diagnosis of heart failure with preserved ejection fraction. And in heart failure with preserved ejection fraction score, the earlier score, a score above 5 is suggestive of heart failure with preserved ejection fraction. So this is an algorithm suggested by the Americans, and we can follow this algorithm to achieve a diagnosis of heart failure with preserved ejection fraction based on the presence or absence of symptoms, which is the initial entry point, followed by echocardiographic and a score system scores. That we should always keep in mind that all patients with normal ejection fraction are not categorized as having heart failure with preserved ejection fraction. The commonest patients we encounter, patients with rheumatic valvular heart disease, who present with, say, orthopnea, PND, leg swelling with ejection fraction of 60, cannot qualify as heart failure with preserved ejection. These are separate group of patients who require separate management strategy. They are not part of FPF patients. Patients with pericardial diseases, right-sided isolated heart failure, cardiomyopathies of all sorts should be seen separated, not as part of patients with FPF. So this is a case Dejene that will lead us to the next part of our discussion, management. This is a 65-year-old female, non-hypertensive, diabetic for long years, who presented with dyspnea on exertion of 1 month, but no cough or orthopnea, blood pressure of 150 by 95, irregular heart rate at a rate of 76 with BMI of 31, clear chest, flat JVP with quiet precordium, with echo revealing a left ventricular hypertrophy with grade 1 diastolic dysfunction and ejection fraction of 60%, ECG with absent POF, suggestive of atrial fibrillation, and eGFR of 62, normal potassium, and hemoglobin A1C of 7.4. She's taking metformin, 850 milligram POBID, glypride, lisinopril, an AC inhibitor, a beta blocker in the form of metoprolol succinate, and rivaroxaban for anticoagulation. So the question is, this patient was diagnosed with heart failure with preserved ejection fraction based on the scores I mentioned earlier. Now she's taking an AC inhibitor. She's taking a beta blocker. AC inhibitor and beta blockers have proven mortality benefit in patients with heart failure and reduced ejection fraction. If they have similar evidence, we are going to see in the subsequent slides. But with regards to the management of heart failure, what shall we do? Shall we replace the AC inhibitor with an ARNI? The first question. She's on lisinopril. Blood pressure control is suboptimal for heart failure patient, 150 by 95. Shall we replace it? You can keep the answers to yourself, or you can tell me the answers. Shall we start on SGLT2 inhibitors? Main of the hour. Shall we initiate an MRA? Potassium is 4.7, so we are okay with hyperkalemia. Would she benefit from addition of an MRA? These are the questions we will try to answer in the subsequent slides. So the goals of management is for patients with HFpEF is to reduce heart failure symptoms, improve functional status, reduce hospitalization, And in red color, mortality reduction with question marks. So I put the question mark because so far we may not have that luxury of reducing mortality in this group of patients as opposed to patients with heart failure with reduced ejection fraction. General measures we do for every patient with heart failure include dietary alteration, exercise, weight control in those who are overweight, and treatment of associated conditions like hypertension. This patient I described earlier is hypertensive, diabetic. She is taking AC inhibitor, which is the first line antihypertensive in patients who are diabetic. So there is no point in replacing an AC inhibitor with an ARNI. And whenever we have a competing competition between the comorbidity and management of HFpEF, we have to prioritize management of the comorbidity based on first line recommended therapy. And say if glycemic control is of significant importance, we should not replace metformin and glypride with SGLT2 inhibitors because SGLT2 inhibitors are not known for significant glycemic control when treated, when given alone. So the last part is pharmacologic management. As opposed to patients with heart failure with reduced ejection fraction, we can't confidently speak of a specific pharmacologic agent that's described as first line in patients in this group. So reduction in heart failure hospitalization was demonstrated in multiple studies, but reduction in mortality has been an elusive concept until now. And in many patients, the good thing is they have comorbidities, and treatment of those comorbidities will likely overlap with management of heart failure with preserved ejection fraction. So trials were described by Dr. Chala in the morning. If you have seen, there are maybe more than 30 years of trials in patients with heart failure with reduced ejection fraction. The outcome was positive from the late-go until very recently. And those drugs were proven to reduce mortality significantly. Dr. And the same group of medications were studied in patients with heart failure with preserved ejection fraction. This includes the RAS inhibitors, MRA, ARNI, and SGLT2 inhibitors. In the morning, charm alternative was described as one of the positive trials in patients with heart failure with reduced ejection fraction, but this was not true in patients with heart failure with preserved ejection fraction. Charm preserved, which was published in 2003, almost 20 years ago, proven that candesartan has only a moderate benefit in reducing heart failure hospitalization without impact on mortality. And the other trial was published in 2014 was TopCat trial, which was done in patients with heart failure with preserved ejection fraction, which compared spironolactone with a placebo in patients with heart failure ejection fraction above 45. And in this, similar to candesartan, spironolactone failed to show significant reduction in the incidence of the primary composite outcome, which was death from cardiovascular cause or hospitalization for management of heart failure. Then came ARNIs in 2014. Their benefit was proven in Paradigm trial, and the same was conducted in patients with preserved ejection fraction, Paragon. But they were for almost 5,000 patients with class 2 to 4 heart failure symptoms were included. But the final conclusion was ARNI, sacubitril valsartan, did not result in significantly lower rate of total hospitalization for heart failure and deaths from cardiovascular cause. Keep in mind that these trials are negative in terms of achieving their primary outcome, but there was a modest improvement in heart failure hospitalization in all the three medications I just described. Then came the SGLT2 inhibitors recently. The first was Impera preserved, which assessed empagliflozin in patients with ejection fraction above 40, where patients were almost 6,000 patients in 622 centers in 23 countries were randomized to empagliflozin or placebo. And these are the group of patients which were included. The primary outcome of a composite of cardiovascular death or hospitalization for heart failure. There were two secondary outcomes. The first was recurrence of hospitalization, and the second was decline in eGFR. This was the baseline characteristics. Probably was worrying is blacks were underrepresented. Only 4.4% of the study population were black. And the outcome was relatively much impressive discussed earlier. And the primary composite outcome was better in empagliflozin with a relative risk reduction of almost 21%, but heart failure hospitalization reduction was even more robust at a rate of 29%. So overall, the outcome suggested that there was no mortality benefit in patients who were on empagliflozin, but heart failure hospitalization reduction was quite significant. This is a summary of the results I just described, where in the primary composite outcome of cardiovascular death or hospitalization, empagliflozin resulted in 21% relative risk reduction. The same is true for, even better for heart failure with heart failure hospitalization at a rate of 27%. This was true across all subgroups except for certain subgroups like Black and other races, where the subgroup difference was in fact not adequately powered, but still the benefit in Black community was questionable. So in summary, empagliflozin led to a 21% lower relative risk reduction in the primary outcome, which was consistent among subgroups, but it did not appear to improve mortality, which is still elusive even with SGLT2 inhibitors. The last trial was the LIVER trial, which was published last August, which tested dapagliflozin in heart failure with preserved ejection fraction. The design, the multinationality, and the number of patients included was more or less similar to Imperial preserved, but this study used multiple inclusion and exclusion criteria. So again, the representativeness in Black community was questionable. Even the percentage of Black patients which were included was lower than Imperial preserved, only at 2.2%. They tested the primary outcome of worsening heart failure and heart failure hospitalization, as well as cardiovascular death. As you well know, whenever there is a composite outcome, it's not as strong in the point as a separate assessment of cardiovascular or all-cause mortality. Patients were followed for a median of 2.3 years. This was the inclusion criteria based on age, ejection fraction, evidence of structural heart disease, and patients were around 6,000 patients were randomized into both. And this was the study design. And the baseline characteristics was more or less comparable. Again, Blacks were very much underrepresented. And the outcome showed that more or less similar to Imperial preserved patients who received dapagliflozin as relative risk reduction of almost 18% in first primary composite outcome. And the quality of life was better in patients who received dapagliflozin as well. And this is the result described in graphs. The first primary composite outcome reduction by 18%. That was driven mainly by reduction in heart failure hospitalization. It was similar across subgroups studied in the DELIVER study as well. Again, the big line that crosses the midline belongs to the Black community for some reason. But the authors describe that subgroup analysis cannot be generalized because it's not adequately powered, and we should interpret it carefully. And this was the conclusion of the authors. Among patients with reduced ejection, preserved ejection fraction or mildly reduced ejection fraction, the primary composite outcome was better in patients who received Dapagliflozin, and this was consistent among subgroups. In the previous trials improvement, the improvement was only 10 to 15%, but in the DELIVER and imperial preserved trials, the reduction even in primary composite outcome was close to 20%. So based on this, meta-analysis was performed for these two trials, and all major 5 large trials involving SGLT2 inhibitors. And the first part was DELIVER and imperial preserved, which included a total of 12,000 patients, and totality of evidence was assessed among the SGLT2 inhibitors studied in patients with reduced and preserved ejection fraction as well. So the meta-analysis showed that there is a 20% relative risk reduction of primary endpoints in patients who were initiated on SGLT2 inhibitors, which was consistent with individual studies as well. And there is a consistent reduction in first primary composite endpoint along ejection fraction spectrum from 41 to 49 and even up to above 60%. And in subgroup analysis, again, the result is similar, and SGLT2 inhibitors have proven benefit in terms of reduction of hospitalization primarily, and quality of life improvement was as well similarly better in SGLT2 inhibitors. Overall primary endpoint of cardiovascular risk reduction when all the 5 major trials, including those performed in patients with reduced ejection fraction, SGLT2 inhibitors resulted in total of 23% relative risk reduction. So in conclusion, this meta-analysis showed that SGLT2 inhibitors in heart failure, either with mildly reduced or preserved ejection fraction, realization, improvement in symptoms, quality of life, which was consistent across all ejection fraction, and the authors concluded that this evidence supports prioritizing use of SGLT2 inhibitors in all patients with heart failure, irrespective of ejection fraction. So with this conflicting, sometimes positive, sometimes neutral evidences, guidelines have been revised, and it was recommended in both ASC 2021 and AHA 2022, which was discussed in the morning by Dr. Chala, that SGLT2 inhibitor should receive a class 2A recommendation. That's the only drug which has received a class 2A. The others, MRAs, beta blockers, ARNIs, all have received a class 2B recommendation. And management of comorbidities is a class 1 recommendation in all society guidelines. This is a summary of the heart failure ACC AHA 2022. We shall initiate diuretics in those who are congested, and SGLT2 inhibitors are class 2A, and the rest are class 2B. So if we come back to our patient, so what shall we do is ACE inhibitors have proven benefit in patients with diabetes. Blood pressure control is suboptimal. Either we have to adjust the dose, or we may add a second antihypertensive, but we should not replace an ACE inhibitor with an ARNI in such patients. That's one thing. Patients who have some evidence of clinical or hemodynamic congestion, we should initiate diuretics, which is the first line therapy. Then we should treat comorbid conditions. In our patient, she is diabetic, hypertensive. The glycemic control is fair, but not optimal. So adding an SGLT2 inhibitor would be the next best option. We are targeting both the glycemic control at the same time manage heart failure with preserved ejection fraction. And the other thing is we can add MRAs as well. The MRA will address both the blood pressure control and manage the heart failure with preserved ejection fraction, which we can do prescribe to the patient described earlier. So this is specific, and second line is put in quotation because it's not based on a strong recommendation as opposed to patients with heart failure with reduced ejection fraction. The second line, so-called second line, include ARNIs, AC inhibitors, and ARMs. In the previous patient, ARNIs cannot replace an AC inhibitor purely for the management of heart failure alone, but if blood pressure control is an issue, we may consider ARNIs in place of an AC inhibitor. So vasodilators should be avoided as much as possible because this kind of patients tend to have increased exaggerated vasodilator response with risk of inducing hypotension. So this is all I have. Thank you. Maybe if you have questions or comments before we hand over the presentation to a different department, or we have one more cardiac topic. Questions, comments?
There is one question from the Zoom attendees. Is there any preference of antihypertensive medications over others in patients with heart failure with preserved ejection fraction with hypertension? So patients with hypertension and heart failure with preserved ejection fraction, in terms of choice of antihypertensives, is there any preference?
Okay, as the question is if there is any preference of antihypertensive medication in patients with heart failure with preserved ejection fraction and hypertension at the same time. The guidelines recommend that whenever there is a competing priority between heart failure with preserved ejection fraction and a comorbid condition, we should prioritize the comorbid condition. The reason being, we don't have a specific recommendation, first-line recommendation for heart failure with preserved ejection fraction, but we have for hypertension. For hypertension, as is going to be discussed tomorrow, we have certain indications based on different guidelines, including WHO, ISH, AHA, and ASC. And these guidelines mostly recommend choice of antihypertensive based on presence or absence of compelling indications. If there are no compelling indications, we may opt for medications that can both address the heart failure and the hypertension. But if there are compelling indications, we should prioritize management of the hypertension. In the previous patient I mentioned, she's diabetic. If we compare ARNI with AC inhibitors in diabetic patients, ACs will take priority. So we should prioritize management of the comorbid conditions because they commonly have a strong evidence recommendation for first-line therapy. The same is applies for atrial fibrillation, diabetes as well.
Thank you, Dr. Seifu, for the excellent presentation. Next, we'll go to. Next, the presentation would be about heart failure and atrial fibrillation. It will be presented by Dr. Kefelegn, who is a consultant internist and interventionologist. And the ethical part and the mechanical part with the heart failure and atrial fibrillation.
Okay, sorry for the inconvenience. So as I said, we'll combine both the mechanical part and the theoretical part of heart in general. So the combination is very synergistically very bad because both are high mortality. On the top of heart failure, if you have atrial fibrillation, it is the same thing that we said in Amharic, Bankertelai Jirodagif. I would like to start with one case, a case with rheumatic heart disease, who had very severe MS and some other valve involvement. She has been symptomatic, very severe MS, atrial fibrillation. She came to our center, and before that, she had peripheral emboli to both legs, femoral legs. And thanks to the vascular surgeons, they did good embolectomy. She was fine with that. So the final step is to do valvotomy. Valvotomy was done. Then these are her vital sign. BP was a little bit high, heart rate tachycardic, regular. INR is 1.5. She's on warfarin. So we'll address this question. Is she at risk for stroke? And what anticoagulant shall we use? What is the target INR? Heart rate is what is the target? Can we use rhythm or rate control? These things, as we go through the discussion, we'll answer. You can see she has very huge left atrium. This almost the whole part of the atrium is left atrium. So that is that's why she has a recurrent emboli from the heart to the down to the leg. And so because of this, valvotomy was done, and that was a good outcome. So the issue is after valvotomy, the severity changed to mild. So we'll discuss the definition of F. Atrial fibrillation, it is supravenous, as you all know, and it is irregular RR interval with no P waves. And but to say clinical atrial fibrillation, we need to have a documented EKG, either 12-lead ECG or 30 seconds documented either in the monitor or in the Holter, whatever. This is the definition of clinical AF, not symptomatic or asymptomatic. Patient, whether it is asymptomatic or symptomatic, they're at risk for stroke. So we use ECG for documentation. As you can see, this is a recommendation in European Society 2020 guideline. ECG is a must to have it to say patient have atrial fibrillation, either 12-lead ECG or monitor or in Holter or device as well. And when we classify atrial fibrillation, it doesn't change it from the long time during our medical era. Proximal within 7 days of the period, it depends on the period. Within 7 days, we say proximal. Up to 1 year, persistent, whether you cardioverted or not, it's persistent. The last two are not different in the definition. Long-standing persistent, up to 12 years, more than a year, but your intention is to do cardioversion or rhythm control in whatever way. But if you accept that atrial fibrillation for a long time with rate control, you have no plan for rhythm control, that's permanent. But anytime that you are changing your idea to do rhythm control, the definition will change it to long-standing persistence. But the other definitions like lone AF, valvular AF, and chronic AF, these are omitted from guidelines because lone AF, previously it was difficult to get the etiology for atrial fibrillation, but nowadays because of technology, the advance of the medicine, the cause for atrial fibrillation is very known, like more than 90%. So no lone AF. And valvular AF, non-valvular AF, before, if there is valve problem, whatever, aortic, mitral, or whatever, the anticoagulation is different. Currently, only two things. If the mitral valve is very severe and moderate to severe mitral stenosis or mechanical valve, these two things needs BK, vitamin K anticoagulant for like warfarin. The others, they are the same, like other atrial fibrillation. How is the epidemiology with AF and heart failure? One is persistent for the others. If you get more atrial fibrillation, you will have more heart failure. The same thing, the other way. So almost in 1/3 of the patients with heart failure, they are atrial fibrillation. Especially if the patient have new onset heart failure, the probability of having AFib is like more than 50%. So in most big registries, more than 150,000 patients in US, 31% of the patients with heart failure, they have AFib. So it is good, big numbers that patients will have. So this is the incidence depending on whether you have heart failure or not. Once you have heart failure, the chance of having AFib will be peak. So whenever the patient have heart failure or AFib, we have to look for underlying atrial fibrillation. The same thing, we have to screen both ways. And the outcome is very bad. Patient having only atrial fib or heart failure, the mortality is 1 or 2 times double. And the same thing, most patients of AFib die not because of stroke. They die because of cardiovascular, pump failure, heart failure. You can see more than 46% of the AFib patients die of cardiovascular problem. And especially new onset AFib with heart failure, they have high mortality. In which subtype of heart failure is AFib is common? In reduced or preserved, it is more common with preserved ejection fraction, as my previous colleagues presented it. Patients with preserved ejection fraction, they have more comorbidities, they are aged, so they share the same comorbidities. That's why it is common. But when you come to the outcome, which one is high, bad outcome? Is AFib with preserved or AFib with reduced? Almost they are the same. In terms of stroke, hospitalization, or days, almost are the same, a bit bad to reduced one. And this is the local data, not AFib with hypertension, heart failure, but only AFib. This is in Jimma town, around 634 patients in population based. They used EKG 12 lead EKG, and they used Charles score to do cross-sectional study. And in that studies, they found 4.3% of prevalence AFib in population. This is not in heart failure patients. And in that, they have seen current smoking, hypertension, obesity, and female sex, they have more AFib than the others. And Dr. Dejene and his colleagues, they also do one research in Black Lion. They did chart review, around 500 chart review, patients with rheumatic disease. And in that, with AFib, most of the, in that study, more than 72% of the patients were female, and around half of them, they have AFib. And the common predictor to have AFib is mitral stenosis, age, advanced age, TR, and large or big LA. These are the risk factors to have AFib and cardioembolic stroke in this study. And what is the underlying pathophysiology between heart failure and atrial fibrillation? They, as we said, they share the same comorbidities like the conventional hypertension, diabetes, CKD, age. These all are common in both groups. And one of, if gets heart failure, it will affect atrial fibrillation because when the patient have congested, increased diastolic LV feeling, that will have atrial stretching, that will stimulate the sympathetic outflow that ends up in atrial fibrillation. Then atrial fibrillation also precipitate more tachycardia-induced cardiomyopathy, atrial kick will be lost, low cardiac outputs, so end up in precipitating heart failure. So one will make bad the other. And this is, then the dilemma, which one is which? Is heart failure is a cause or the atrial is a cause for the other one? So both are cause for each other. So these are some reviews. In these reviews, can we predict if the patient have AFib? Can we predict that which group of patients will have heart failure, clinically or with echocardiography? In this paper, if the patient in advanced age and underlying comorbidities like hypertensive diabetes, the probability of having heart failure is higher than the others. And the same thing, rather than proximal AFib, those who have permanent atrial fibrillation, they are at risk to have heart failure. And the other thing with echocardiography, I don't think we'll do this much detailed echo, especially me. These are the different papers, the year are there, and the number of patients, and the last is the parameters, the predictors of echo for having heart failure, especially if the patient have large LA and E prime to A prime or diastolic feeling problem and LV fibrosis, reduced ejection fraction, age. These are the predictors to have heart failure in atrial fibrillation. Is diagnosis clinically, it's not easy. Both share the same symptom. One of those have palpitation, dyspnea, shortness of breath, or the other, the same heart failure or atrial fibrillation. They could have the same symptom. So in every patient with heart failure, we deliberately look for atrial fibrillation because the management will differ. And as we said, in 1/3 of the patients with heart failure, they have AFib, and we have to do anticoagulation or rate or rhythm control. We need to diagnose the diagnosis of atrial fibrillation in heart failure. So a patient with AFib could be asymptomatic, but it doesn't mean he has no risk. They could have risk of stroke, even if they're asymptomatic, or symptomatic, but not hemodynamically stable, symptomatic in many ways. As we said, they could have symptom of palpitation or feeling problem like heart failure, or the patient come with hemodynamically unstable. So we'll discuss some of them. So how we're going to screen the patient who have heart failure with AFib? We have, thanks to technology, we have many ways. We can do echo or EKG, Holter ECG, or smartphones. They are very good to detect the AFib at least. So different watches are there with application, and our patients are coming, look at my heart rate, look at my AFib with their mobile phone or their watch. So we can advocate to use that. And in heart AFib, we have to answer these 4 S. What are these 4 S? The first S is how to be the burden of the stroke in that patient. So we have to use Charles-Bus score. This is easy. The Charles-Bus score, we can do it at any OPD. Then we label the patient is in at high risk or low risk. Because with that, we can going to have anticoagulation. Then second is symptomatic. Is the patient symptomatic? We can use the European questionnaires. Is how the patient is symptomatic, quality of life. And the other is how is the burden of AFib? Is permanent, paroxysmal, or persistent? So this we classify according to the time. And finally, is the patient have underlying problem? Is there any cardiac issue, comorbidities? We have to answer this. And when it comes to the management of the heart AFib with heart failure, I think heart failure was addressed very nicely from reduced to preserved ejection fraction thanks to my colleagues. And so we have treated heart failure, especially some of the heart failure medications like MRA, AC inhibitors, or ARB. They have some delaying the new onset of atrial fibrillation. They don't treat AFib, but they may delay the new onset of AFib, especially MRA and ARB AC inhibitors, but doubtful of beta blockers. Beta blockers, they may not prevent new onset of AFib. So we have to treat the comorbidities and then go for rhythm, rates, or anticoagulation. So we have seen the 4S, how to classify what is the symptom, what is the stroke risk, the comorbidity. When it comes to the management, we need to address the ABC. Does the patient need anticoagulation? Is in high risk or not? That will address by Charles-Bus score. We don't use only Charles-Bus score. If the patient have AFib with severe MS, automatic, no need to do Charles-Bus score. If the patient have mechanical valve, no Charles-Bus. The rest of AFib should be done Charles-Bus score to label them he needs anticoagulation or not, whether he has heart failure or not. So those who have, for male is 0 is low risk, for female is 1 is low risk. And the other above 2 and 3 is high risk, so they need anticoagulation. So to see some of the studies, rate versus rhythm, which one shall we control? Patient who have AFib with heart failure, does rate control help or both help? The early treatments, this is before catheter ablation, that is cardioversion, electrical cardioversion, plus antiarrhythmics, including amiodarone. So these are very low ejection fraction, less than 35. Primary outcome was days or other cardiovascular events. And yes, those who have rhythm control, they have been stayed sinus rhythm for a long time. As you can see here, these are rhythm control, rate control. They have been in sinus for a long time, but the outcome is negative. There is no difference between rates or rhythm control. This is older studies actually. So whether you control the rate or the rhythm that time is fine. Then the other study, the same thing. These are pharmacological or cardioversion, not ablation. This is also another study. We have AFib or atrial fibrillation, low ejection fraction with drugs with anti-arrhythmic drugs. And this also shows patients stayed for a long time in sinus rhythm, those who have the trial group, but in the outcome, there is no difference. regarding the primary outcome. So it's a conclusion. But there are other studies you can see which they used low ejection fraction, heart failure, rhythm versus rate control. If it's the last one, there is no superiority from one to the other. Then why should I fight control rhythm with amiodarone with side effect or cardioversion? Why not rate control if that's the same? So when you come to rate control, how far we can go, how low we can go. So there are studies in the race 2 trial. Can we make the heart rates 80, 110 during exercise, sitting? There is no difference between linear rate heart control or street control. I mean, less than 80 or 110, there is no difference. So at least for our primary treatment, we have to target at least 110 as our initial target. And this is what I said. Lenient means above 110, less than 110, and the strict one more less than 80. When it's controlled strict, it's not without too much pharmacology, it's not without hypotension, it's not without side effects. So there is no gross difference between these two. So what guidelines say? How far we can go down? 110 is accepted. If possible, if the patient is still tachycardic symptomatic, we can go down up to 80. Otherwise, as initial, we can target 110. So this is what drugs you can use. So you label the patient. Is there reduced ejection fraction, preserved ejection fraction, or COPDs? If it is reduced ejection fraction, better to use beta blockers and digoxin. It is preserved calcium channel blockers and hydropyridines like diltiazem and verapamil. We don't have diltiazem. Verapamil you can get sometimes in black markets, and beta blockers. So beta blockers across the all one, you can use beta blocker. Maybe different with type of beta blockers in patient with reduced ejection fraction. The others, I don't think we have select type of beta blockers. And if still symptomatic, we have to combine with the other second line, beta blocker plus digoxin, or beta blockers with diltiazem take care of bradycardia. And if still symptomatic, no change, patient have tachycardia, we may go for other antiarrhythmic drugs like amiodarone or the other. If still symptomatic, we may go for ablation, like we can ablate the AV node and put pacemaker. So the problem will be the patient will be dependent, pacemaker dependent after that, or CRT. And then you have to think of rhythm control with another way. So these are the guidelines. If the fraction is more than 40, as you said, we can use beta blocker or calcium channel blockers, less than 40, digoxin beta blocker, and heart rate 110, this is class 2A recommendation. But the science is evolving. Now the EP guys, and thanks to the St. Paul group and Cardiac Center as well, and a friend from France, recently a few patients have done in St. Peter, St. Paul ablation. That's a very big thing for the country. So the ablation will come to us as well. So in the era of catheter ablation, it's not the same as before. This is Castelli, a study, patient who have 365, low ejection fraction, AFib, and they did medical therapy versus ablation. So this is invasive with a radio frequency ablation. And you can see how the rate will be in sinus rhythm. Those who have medical therapy, they have high AFib burden. Those who have ablations, they have low AFib burden. The logic behind is if you keep the patient more in sinus rhythm, the pathophysiology which we discussed, left atrial fibrosis, remodeling will be bad if it's in AFib. So keep him in a sinus rhythm. So this was the outcome. The outcome outweighs more. Those who have catheter ablation, less mortality when patient was AFib and heart failure. If we do catheter ablation, and this is so, this one positive trial, the same thing, all mortality or hospitalization or deaths is much better for ablations than medical therapy. This is the conclusion. So those who have patients who deserve to have ablation, we need to do catheter ablation. It's the same another study. Shall we do it early or late? Before the AFib gets bad and bad, before it's making more remodeling and fibrosis, If you do early ablation, that will be one advantage for the patients. And these are too many studies are there which are favoring this one are ablation. You can see 50% of them undergone pulmonary vein isolation ablation. So most of them have superiority, the positive outcome when compared to medical therapy. This is the same. Doing ablation doesn't mean you abolish the AFib, but you keep the patient more time in sinus rhythm. So keeping the sinus more in sinus rhythm, the patient will have less remodeling and the risk of other cardiovascular bad outcome will be less. And if you, by doing ablation, in some reports, the ejection fraction will improve up to 10%. And the prolonged, as I said, keeping it in sinus rhythm is the basic that's the pathophysiology to keep in this outcome. Do all patients benefit from this? No. A patient or advanced age, big LA, already fibrous, they will not benefit. But younger age and LA size good, with MRI, I've been discussing in the morning, cardiac MRI is coming to more picture in cardiology. Cardiac MRI which has less fibrosis in left atrium, and ejection fraction is good, and direct cardiomyopathy rather than ischemic heart disease, they will benefit more from ischemia treatments. So when we finalize rhythm control, if the patient is symptomatic at the rate control, if symptomatic, we may have to consider rhythm control with pharmacologically or cardioversion or ablation. At least we have pharmacological or cardioversion. If the patient have, especially those who have tachycardia-induced cardiomyopathy, they will benefit if you do cardioversion. Otherwise, the patient end up in heart failure and a reduced ejection fraction. So this is a recommendation. The class 1 recommendation is those who have tachycardia-induced cardiomyopathy, they will benefit more from doing rhythm control. So then we come to, so we have seen rate control, rhythm control, comorbid treatments, and finally, we shouldn't forget anticoagulation. Anticoagulation, as we said, if the patient has severe MS, moderate to severe MS, we have to use BKA, warfarin. And otherwise, for the rest of the other patients, we have to stroke risk classification with Charles-Vass score. If Charles-Vass score is more than 2 for male and more than 3 for female, that patient by definition is in high risk, so he needs anticoagulants, either warfarin or the newer anticoagulants. And these are, there are big studies I can show you here. There are many studies during the era of warfarin. They compare warfarin with placebo, aspirin with warfarin, aspirin to clopidogrel, and finally they came to newer or direct oral anticoagulants. Four of are there done. We have rivaroxaban in the country. So on these studies, the newer anticoagulants are much more better than warfarin in terms of prevention of cardioembolic or hemorrhage. So then subgroup analysis was done for heart failure. And from these 4 NOACs subgroup analysis on those who have heart failure, if you see the number of heart failure patients in these studies are much better. And dabigatran 27%, in rivaroxaban 63% of patients have heart failure. So on this subgroup analysis, those patients who are AFib with heart failure, is this vitamin K or NOACs? NOACs is much better than vitamin K, and but it should be the higher dose. Rivaroxaban 20, not 15, and apixaban 5, not 25. Otherwise, if you use lower dose of NOACs, it's the same to warfarin. As you can see, if you use the higher dose of NOACs, it's 24% much better than warfarin. The problem is they're expensive. So this is a recommendation. NOACs are preferred than warfarins, and we have to use Charles-Vass score. And it's higher risk patients, they need anticoagulants. And we use this same Chartval score. As Chartval score is getting much more, too much risk factors, the chance of having stroke is much. And don't forget also the patient may bleed, but having this has bleed score more than 3, the patient is in high risk of bleeding. But it doesn't mean that you have to not allow him to give anticoagulants. That to know the risk of bleeding is to see them frequently, or to treat the bleeding factor. Is alcoholic, is INR is high, hypertension. Otherwise, whatever risk has bled is high score, we cannot deny to give anticoagulants. It's only it will help us what's the patient risk of bleeding. And this is, we categorize the patients is in high risk or low risk. In high risk patients, we start anticoagulants, better than NOACs. If patient have valve, mechanical valve, or severe MS, we have to use warfarin, that's automatic. Otherwise, there is one algorithm that which one to choose, which patient will respond for warfarin or rivaroxaban, for example. So this is the algorithm you can use if female sex and tobacco chewer, Caucasian, and younger age. If is more than 2, you have to more suggest to use newer anticoagulant or the direct anticoagulant than warfarin. But if these factors are not there, the patient may respond for warfarin, and you have to keep your target INR 2 to 3 in 70% of the time. So we need to do INR frequently, at least every month, or the first few time every 2 weeks, to keep the target in above 70% of the time. Otherwise, giving warfarin and sending count back after 3 months, I don't think it will help the patient a lot. And so in summary, heart failure and atrial fibrillation, I'd say, as we said, 1/3 of the patient will have one of the other. And if we diagnose both of them, we optimize heart failure treatments. And AFib wing, we have to look for anticoagulant. Does he need anticoagulants? Does how long we can go down to rate control and rhythm control, which patients, selected patients, they may benefit for rhythm control. And when back to our case, so she has MS, but that was changed from severe to mild. So can we use NOACs? Still in AFib, but she's in high risk. She has very big LA, as we have seen, and female sex. She has previous emboli, whatever, she's in high risk, but even if MS is mild. And if she needs anticoagulant, no question, yes. Which one? That I cannot answer. Maybe warfarin, yes, likely. But there's no studies after valvotomy, if the MS is changed to mild form, to give a NOAC or not. So by now we give warfarin. Those patients need warfarin. And what will be our target INR? 2 to 3, at least 2 to 3, we have to keep it. And what if she gets pregnant? We can still give warfarin. If the dose is less than 2, especially in second trimester, we can allow warfarin, especially if they require low dose of warfarin. Otherwise, at the end of pregnancy or the beginning, we have to consider heparin. And rhythm control in these patients doesn't work because very big LA and already fibrosed, the chance of recurrence will be high. And what are the good and bad indicator of the catheter ablation? She has very big LA, so that's not good for ablation. This is what I have. Thank you very much. If any question, welcome.
Okay, if you have any questions, we'll entertain questions.
There is one question from the Zoom attendee. What is the management approach to atrial functional MR or AFMR is the question. What is the management approach to atrial functional MR?
If I understand, I don't know. How do you assess atrial function? Maybe.
It's I'm just reading it. It says, it is by a cardiologist, the question itself. How is the management approach to atrial functional MR? Probably we can ask him to elaborate more. Okay, so I think let's go to the next question.
Say maybe atrial fibrillation is functional MR.
Mitral regurgitation.
Yeah, that's functional.
If that is the reason, maybe I have to answer both. We can assess atrial function, left atrial function. One is with echocardiography, we can do velocity, and the other is cardiac MRI, which is the best. You can assess the fibrosis. That is to assess the LA geometry and function. The other thing is different. If patient have MR and atrial fibrillation, we have to use charge VAS score. The same like other patients, unless they have severe MAs and mechanical valve, we have to use the charge VAS score. If charge VAS score is more than 2 for male and 3 for female, he will need anticoagulants. Otherwise, he's just like other patients. If he with hypertension, if he with CKD or whatever, so it is valvular, but now the name is changed, it's not valvular.
So the second question is, what is the role of heparin in the management of patients with atrial fibrillation and heart failure? And another question, management of anticoagulant in patients with atrial fibrillation, score 3, and history of hemorrhagic stroke in the past 1 year. I think you tried to mention it a bit, but probably we can elaborate more.
The place of heparin in AFib, one is in pregnancy. In pregnant patients, especially the 3rd trimester, we have to use heparin, because if you use warfarin and the patient get deliveries, the patient have the baby could have intercranial hemorrhage and the patient may bleed. So that's one other thing. The other thing during acute management, if the patient came with AFib, collapsed, so we have no time to give, and there's a time will take for warfarin. We have to give heparin and cardioversion. So in acute setting and in pregnancy, it will have a good impact with warfarin. The other thing, stroke. Okay, I got it now. Okay, after hemorrhagic stroke, when do you start anticoagulant? I think this will be, we should have invited neurologists today. Invited nephrologists and endocrinologists, but there is no. But that also will not stop us from giving anticoagulants. We have to take an opinion from neurologists that says if it's big hemorrhage and the other risk of recurrence of hemorrhage, we may wait. Otherwise, I think in a few months, I forget specifically what months, in a few months we have to resume the anticoagulants. Okay.
Thank you. I just want to ask a patient who is on new oral anticoagulant agent who has a GI bleeding after NOAC. Would you reverse him to warfarin again, or correct the bleeding and then continue with oral anticoagulant agent? That is the new oral anticoagulant agent versus renal failure.
Thank you. It's a good question. There are two questions. GI bleeding with NOACs and renal failure with anticoagulation.
No.
Two questions,
Yeah.
Yeah. If a patient has at high risk with charge VAS score, if the bleeding is reversible because of the cause of the bleeding is surgically or whatever.
No, I need secondary to the anticoagulant.
Okay.
Secondary to anticoagulant.
There is no choice which one to choose from GI bleeders, but the said to be reversible one has somehow high bleeding in GI patients, unless because of the, I don't think it will change whether we put it in warfarin.
More GI bleeders are reversible. Maybe we have to switch to other NOACs like AB7. But changing to warfarin makes a difference. I don't think so. And a patient with CKD, depending on the creatinine clearance, I think the nephrologist came good time. Depending on the creatinine clearance, we can give NOAC rather than Madamki warfarin. But they are low, like creatinine 30. We accept Arixaban. The others, Dabigatran, I will not give them. So this for those who have low injection creatinine clearance, we have to choose more warfarin. As the others, not better than Arixaban is able to be better because it can go down to 15, below dose. And if you have creatinine 30 to 60, you can decrease the dose. So about 20 to 50, and the same Arixaban from 5 to 15, the current 30, can give them half dose. You can answer the question. Thank you, Dr. Kefelegn, for this nice presentation. Just, I have some questions, maybe two things. One is regarding this mechanical obstruction for mitral stenosis. Is there any role for relieving that obstruction for atrial fibrillation management as well? The second is the role of ablation in mechanically obstructed patients. The outcome, any idea do you have? Maybe patient have MS, so doing as a management electrophysiology ablation. So any visible things for managing those patients with that way of management? Plus, can we take as MS as a management for atrial fibrillation without using those drugs? That's the question. The other is maybe the one is said hemorrhagic stroke with heparin management. Any role for LA appendage close to replace that management? Thank you.
Thank you, Dr. Abdu. I think those who have mechanical things, surgically or interventionally, should be corrected, because the main problem, for example, for severe MS is the mechanical obstruction, plus maybe the arrhythmia, tachycardia. So even if you're doing with a standalone the ablation without opening the mitral stenosis, the recurrence rate of AFib is very high. And the ablation is not straight procedure. It is invasive. The patient could have tamponade, perforation. So those patients who have benefit should have to be done. I don't think they will benefit a lot without opening the mitral valve to do ablation. During surgery, my friend is a surgeon. During surgery, they can do maze procedure, mitral valve surgery, plus they can cut and sew or cryotherapy. They can do maze procedure for AFib. Otherwise, they can also do thoracoscopy surgically, but not for mechanically obstruct. I haven't seen reports like that. And the other LA appendage closure, surgically or by device. Surgically, they can do during surgery, they can remove the LA appendage closing. And with device also, you can close, especially those who have high bleeders, I would say. For example, aneurysmal. Patient could have aneurysm, but high risk for stroke, cardioembolic. So these patients, you have to put LA appendage device. And it's expensive, may not be easy for us, maybe in these few years. Okay, Dr. Shiviko.
Thank you, Cafe, for your elaborative presentation. Just to give a comment on surgical perspective. So surgically, we can do the cut and sew type of the maze procedure. The control is usually is not, our aim is mainly to achieve sinus rhythm, but usually we end up in controlled ventricular rate, but it doesn't stay longer because the pathophysiology or the mechanism behind development of atrial fibrillation is that the macro retrans circuit on the atrial wall. They can form it through that scar tissue also. So they can have recurrent attacks. So nowadays, given the type of patients that we are having during surgery, we don't want to waste time and then end up in a dead patient. Because when you do these things, patients are already having precarious physiology, then we'll end up losing them on table. So it depends on what we're going to do. And the other thing is LA reduction with LA appendage closure. Rather than excising the LA appendage, what we do is we close it from inside, because we have to keep the input of the natriuretic peptides. So to keep that one, we just close it from inside. Just as a general comment, because as we are discussing those guidelines from European society mainly, and sometimes from American societies. But the type of patients that we are treating in our setup are different. Like patients who are having RHD, okay, maybe some patients might have hypertension with related to atrial fibrillation. Can we really use those guidelines as a kind of a guide to manage our patients in our scenario? Because we have got different subsets of patients in Ethiopian context versus those patients who are put on guidelines on European Society of Cardiology. So what is your comment on those things? Thank you so much.
Thank you, Shi, for your supplementation in the surgical part. And guidelines, I think unless we have data, we cannot reject everything that we are accepting unless we have no data. But we can customize for individual patients. As I said, we have, of course, patients who have AFib with hypertension, diabetes, CKD, or valvular patients, especially mitral. Most of patients, when you open the mechanical parts, I mean surgery or into valvotomy, the patient have very good relief. Then the issue of rhythm control or rate control will come. At least for us, we can do rate control. We have everything at hand. And anticoagulation. There are too many young patients coming stroke because of anticoagulation. Rhythm control is the second step. We can do rate control, rhythm control, whatever the patient, we have to use Charles Bass score. But the population of rheumatic and non-rheumatic are different. For example, non-rheumatic patient hypertension with AFib, we can try with cardioversion. We have done some of the patients cardioversion to decrease the burden of palpitation and AFib. They are fine. So, but in rheumatic, I don't think we have to do rhythm control with cardioversion, but we can do rates and anticoagulation.
One final question. There is a lot of good feedback from those who are attending online. In those patients who had been reverted to sinus rhythm, how long are we supposed to continue the anticoagulation?
Okay, this is also a good question. Okay, we cardivert him, he became sinus. Sometimes also when you do valvotomy, the patient change to sinus, or sometimes we change to AFib. So if you change to sinus, and there is no mechanical valve or no severe MS, we continue for 2 months, then you score them with Charles Bass score. Again, if they have Charles Bass score still high, you have to continue for life. So what is our judgment is, are they at risk of stroke? We use Charles Bass score. If it's high, we continue for life. If it's low risk, we can stop.
Okay. Thank you, Dr. Kefelegn, for the very excellent presentation. Now we will continue with the next presentation, which is heart failure and CKD. I would like to call Dr. Addisu, who is a consultant internist and nephrologist in Addis Ababa University College.
Good afternoon. በጣም ትግስታችሁን እያየሁ ነበር ከኋላ ስለተቀመጥኩ። An afternoon like this on Friday, very attentive audience like this, I think must be appreciated. And particularly to attend the cardiology symposium full of guidelines, recommendations, so many of them. So so it must be appreciated. So and thank you for giving me the chance to talk to you in a cardiology symposium. It's heart failure in CKD. I think like one of the biggest things that cardiology professionals would hate would be, and anybody would hate, is like managing patients with CKD, because you have a lot of concerns when you're doing, when trying to optimize medical therapy and so on in this particular instance, and there are lots of unknowns. So we're here to discuss parts of the unknowns and some of the things which are known. So heart failure, CKD, Is there any interaction? How do they interact? I would try to highlight. And diagnosis of heart failure in CKD. Are there any challenges? And the main theme probably you've been discussing throughout the day is like providing optimal guideline-directed medical therapy. What are the evidences in patients with CKD and also in the ALS population? If we have some time, we'll discuss a little bit about diuresis and ultrafiltration. So a patient, a real patient, 58, is a man, type 2 diabetes, hypertension, heart failure with reduced ejection fraction. Etiology was presumed to be ischemic. Ejection fractions, variable estimates. Most recent estimates are around 20% to 25%. So he has CKD with progressive decline in his GFR. Most recent are around 17 to 20. The drop in GFR in the last 1 year was like about 7 to 10 ml per minute. He was on enalapril 5 milligram twice a day, carvedilol 25 milligram twice a day, and furosemide 80 milligram twice a day. And since a year back, he was on DAPA 10 milligram a day, aspirin and statin. He has class 2 symptoms. In the last 1 year, he's been hospitalized twice for decompensated heart failure, blood pressure 110/60, clinically euvolemic, and potassium 5.1, albumin 3, hemoglobin 11.6, had a ferritin of 123, and transferrin saturation was 12%. So this is a very common, typical sort of patient. You would see diabetes, hypertension on background, heart failure, CKD, progressive, and treating physicians are trying to give the possible guideline-directed medical therapy. So at this juncture, which intervention is likely to be evidence-based and would be beneficial to the patient? Lots of intervention mentioned here, changing the enalapril to ARNI, increasing the dose of the SC inhibitor. He's on 5 milligram twice a day, or withdrawal of the SC inhibitor, adding an MRA, spironolactone, or if you get a propranolol, start erythropoietin or erythropoiesis stimulating agent, start IV iron. So he has lots of things to intervene, and which one would be beneficial? By the power vested on me, I have the power to ask anybody to respond to the questions. Anyone who would like to just shout on each of the interventions? Would you like to change the enalapril to an ARNI? Yes, no. Adhana has been my mentee for a long time. He's no more my mentee. he's into cardiology now. So would you change enalapril to ARNI? You wouldn't change, okay. And increase the dose of the ACE inhibitor? GFR is 17 to 20. No, okay. So any other who has been my mentee because, all right. So withdrawal of the ACE inhibitor. Would you consider withdrawing the ACE inhibitor? GFR is declining and so on. Potassium is 5.1. Yeah, I have seen two heads consecutively. One was no, and the other is yes. So, so adding spironolactone. Okay, anyone might think because his guideline-based medical therapy is not optimized, he's still symptomatic. Erythropoiesis. No, I've seen Adana saying no. Start IV iron. Yes, somebody said yes. Okay, we'll see. These things are sorts of the agendas that we see in CKD patients. So heart failure and CKD, they have a bidirectional relationship with a considerable overlap, and they are of epidemic proportion. And one would accelerate the presentation as well as the progression of the other. And having both increase the risk of hospitalization, rehospitalization, requirement or progression to require renal replacement therapy and days. So diagnosing heart failure becomes challenging, particularly heart failure with preserved ejection fraction in patients with CKD and end-stage renal disease. And we expect to some of the therapies of heart failure, patients with CKD might have some optimal response. And of concern is increased toxicity to treatment. And also a more important concern is there is paucity of evidence of heart failure therapies, particularly in advanced CKD, end-stage kidney disease or dialysis population, because in most of the landmark studies, these populations have been excluded by design. So extrapolation from existing evidence in individuals with no CKD or with less advanced CKD, which is GFR above 30, is very difficult to the advanced CKD and end-stage kidney disease population. So in CKD population, CKD is a risk factor for the development and poor outcome of heart failure. So CKD patients, after excluding those who have heart failure at entry, if they are followed and the incidence of CKD, de novo heart failure in the CKD population can reach to as high as 20%. And compared to transplant population, the other CKD population, particularly the hemodialysis population, has higher risk of development of CKD. And chronic kidney disease, this is from the PRESERVE study network. Chronic kidney disease being seen across different GFR categories and outcomes related to heart failure. The GFR declines, days from any cause, in heart failure patients with CKD significantly increase. If you see the GFR category less than 15, both with preserved ejection fraction and reduced ejection fraction, there is 3 to 4-fold increment in heart failure outcome, mortality, specifically mortality. So CKD, it's a progressive increment in mortality in heart failure patients who are having CKD, which is graded to the severity of GFR declinement. So CKD predicts poor outcome in all heart failure phenotypes, be it with preserved or reduced ejection fraction. So this is a large Swedish registry which has shown also the same thing, 5-year, 1-year mortality in patients with CKD and heart failure, be it preserved or mildly reduced or reduced ejection fraction, there is an increased mortality. So compared to the general population, this is not heart failure specific, and CV mortality in patients with CKD is high. If you compare it with the general population, like a 25 to 34-year-old person with CKD, which is based on just GFR category less than 60, would have a mortality, CV mortality, which is similar to a 75 to 84-year-old person. So that's the lower graph that shows you. In light blue is general population, male, female, color, white. So as you age, yes, CV mortality increases, but above the red dotted line is CKD mortality if you see the younger population. So as the age goes up, the mortality increases, but the CKD mortality is very high even in the young population, which is CV-related mortality. So CKD is associated with high cardiovascular-related mortality. This is from another cohort, which shows the same thing, CKD associated with high cardiovascular disease-related mortality. So to describe the relationship between the kidneys and the heart, people coined the term called cardiorenal, the cardiorenal syndrome, cardiorenal connections, then this is to classify, to organize knowledge. It's nothing, but it is just to sort out that. So cardiorenal syndrome is just to show there is a talk between the two organs, and generally a maladaptive one, yeah, when it becomes a maladaptive, could be bidirectional, and the relationship is hemodynamic, neurohormonal, and also inflammation plays an important role. And there is a current understanding of cardiorenal syndrome, particularly in the acute setting, the dominant role of renal venous congestion, which I will mention a bit when we discuss about diuresis, some contribution from the low cardiac output of heart failure, and this is how the cardiorenal syndrome is classified. I think you've heard about it. So when we talk about CKD, we're talking about patients with cardiorenal type 2, which means having an existing cardiac disease that is leading to a chronic kidney disease, or it could be a renal-cardiac sort of relationship, which is type 4, you have CKD, and a pre-existing CKD leading to a cardiovascular abnormality, heart failure. So type 5 is a sort of thing, we have a systemic disease like amyloidosis, which can affect both and so on. So this is like typing to help you. So cardiorenal type 1 and 2 are cardiorenal, a cardiac problem resulting in renal, and types 3 and 4 are renal cardiac sort of acute or chronic. 1 is acute, 2 is chronic, 3 is acute, 4 is chronic, and type 5 being. So this is cardiorenal, cardiac. There is a connection between them. How do they connect? The mechanisms, hemodynamic, inflammatory, and neurohormonal. The hemodynamic, venous congestion. I would be emphasizing on venous congestion a lot because the thought previously is low cardiac output, but nowadays, like congestion plays, and the pathophysiological understanding, congestion plays a big role in increasing renal interstitial edema and subsequent related issues with that. And relieving congestion is a very important part of addressing cardiorenal syndrome, particularly in type 1. Neurohormonal, there is sympathetic nervous system activation, increased AVP, RAS activation, resulting in vasoconstriction as well as sodium retention. So the cardiac to renal talk, this is what I was trying to mention, and the venous congestion. CKD, end-stage renal disease leading to heart failure. Does it contribute to heart failure causation? Just the fact that somebody has CKD. Yeah, the first and the most important thing is both CKD and heart failure cause common risk factors or common etiologies. Diabetes, hypertension, old age, and other cardiovascular risk factors are shared, yes. But the fact that you have CKD, low GFR state, or persistent albuminuria, proteinuria, can contribute to heart failure causation itself. Increased afterload, of course, when we talk about afterload, mainly blood pressure contributes. Arterial stiffness is increased in advanced CKD. And the contribution of AV fistulas or AV grafts cannot be ignored. They were thought to contribute to just high output state, but there is evidence to show high functioning fistulas can by themselves cause heart failure or worsen an existing heart failure or make decompensate a compensated heart failure states. So they contribute this way. Increased preload, yes, as GFR declines and albuminuria worsens, there is an increased sodium and water retention, and that increases preload. And there are cardiomyopathic factors which affect remodeling, fibrosis in patients with CKD. Patients with CKD have high risk of LVH and also myocardial fibrosis, anemia, and impaired iron utilization contribute to development of cardiomyopathy. Profibrotic factors which start to increase early in CKD, like FGF23, which is a phosphaturic hormone. Inflammation is prevalent in CKD. Uremic toxins are cardiomyopathic, so this all can contribute to development of CKD-related heart failure or heart failure development after diagnosis of or development of CKD. As I said, it's always a bidirectional relationship, but just to highlight how CKD can contribute to heart failure. So chronic pressure overload, progressive venous volume overload, and cardiomyopathic factors. So diagnosis of heart failure in CKD. I always feel comfortable to diagnose CKD, but I don't think it is very easy to diagnose heart failure. Heart failure diagnosis is much more difficult than diagnosing CKD, because CKD diagnosis just lab data, you have lab and you calculate GFR, durations and so on, that's fine. There is nothing clinical in CKD diagnosis. You don't use any clinical parameters. So you would say this patient has got CKD, have known his GFR or albuminuria. But with heart failure, you need signs, symptoms to be there, which are quite non-specific, yeah? And then you depend on echocardiography, okay, which is fine, reduced ejection fraction, that's okay. That can be there. The structural abnormalities, you can try to do that. But heart failure with preserved ejection fraction or mildly reduced ejection fraction, it becomes quite difficult. And when CKD is there, it complicates the matter because you have edema, shortness of breath, all of that, things, anemia, which can contribute to the symptoms that you have. So it is very difficult to say this patient is in heart failure with preserved ejection fraction, particularly having an advanced CKD. And in the CKD population, all phenotypes of heart failure have increased prevalence, but with preserved ejection fraction is even higher. So it becomes a difficulty. So diagnosis of heart failure is not as simple as it looks in patients with CKD, particularly if you can't demonstrate structural abnormality on your imaging. So there is no accepted definition or criteria to say this patient has got heart failure while there is advanced CKD. Volume overload can occur with both. Echo supports the diagnosis, but not always. And the role of biomarkers in CKD is also complicated because BNP, internal proBNP, they are increased in CKD by themselves. So they are increased in CKD because of volume overload and also low clearance, low clearance. And particularly internal proBNP is more affected than BNP. And normal values also cannot rule out heart failure with preserved ejection fraction because they can still remain normal. The good thing about these tests is they have high negative predictive value. So if you have CKD, expect the patient with heart failure, and if they are normal, then you can safely exclude heart failure. But the presence of high BNP or internal proBNP for diagnosis, for prognostications, it becomes very difficult. So for earlier stages of CKD, you can use standard cutoff. For stage 3 to 5 CKD, BNP higher than 200, some say 250 can be used, but for internal proBNP, there aren't very agreed cutoff point to suggest the presence of heart failure. So that's a diagnostic challenge. And management-wise, for heart failure with reduced ejection fraction, where there's a lot of evidence, which we have been discussing, do patients with CKD enjoy the same type of evidence-based guideline therapies, guideline-directed medical therapies for as in patients with no CKD or earlier stages of CKD. So management of heart failure with reduced fraction, there's strong evidence now to suggest this combination of therapy, the quadruple therapy, to be started earlier on or as a combination. And there are data from many cohorts showing that RAS inhibitors are suboptimally prescribed in patients with CKD because physicians are afraid of hyperkalemia, worsening in kidney function. And SGLT2 inhibitors are not studied in GFR less than 20 in both CKD as well as heart failure studies, and they are not studied in dialysis population. And most landmark studies of any sort have excluded patients with GFR less than 20 and those on dialysis. So it becomes a problem for management. So this among the quadruple therapy that you would like to initiate, the three of them are directly associated with changes in the renal function. So SGLT2 inhibitors, ARNIs, or AC inhibitor, ARBs, and MRS affect renal function. They affect intraglomerular pressure, and intraglomerular pressure natriuretic relationship is affected. So when you start these therapies, you can have worsening renal function. The things are like transient and they are not a big problem. Some people use pseudo worsening of renal failure, because if you follow these patients particularly if you start them at initiation, they wouldn't have any worsening subsequently. Some use true worsening in renal function. So you congest them, started guideline-directed medical therapy, but there's worsening and it remains there. And worsening in CKD, which never returns, can happen when you start these treatments. But the initial transient changes generally look benign as opposed to the fear that we have. Regarding evidence, so if you look the CKD4/5, the red panel, and look into all evidence-based heart failure therapies, evidence are absent, weak. It's only beta blockers where you would have some better evidences in advanced CKD. CKD G4, which is eGFR less than 30, and G5, which is eGFR less than 50. So in advanced heart failure, particularly, there is no strong evidence. So in CKD3, 1, 2, there are strong evidences. So we generally treat as we would have treated patients in CKD. But in this category of individuals, there is lack of evidence. So I'm not sure if this is just to highlight. If have just highlighted in red the exclusion criteria of some of the major heart failure trials. There are inhibition and ARNI studies, the paradigm, beta blockers, mineralocorticoid receptor antagonists, MRS, SGLT2 inhibitor. Now, the lowest evidence in GFR that you would get is in the SGLT2, like less than 20. Some of them older studies use creatinine-based equation, which would not come to a GFR not above 30. So all of them that you have been citing, discussing, have excluded the CKD G4 and G5 categories. And the other problem, I think this is changing and improving in cardiovascular studies, is outcomes are mainly MACE outcomes. Renal outcomes nowadays are being included as major outcomes, but in the previous studies, either are included as safety outcomes, secondary, or some of them haven't included in safety outcomes. So including it as major adverse renal and cardiac events, because some of them could progress to chronic kidney disease, renal replacement therapy, and some of them would have acute kidney injury, which could be transient, or some of it can lead to progression to CKD. This is something which we are seeing these days, and it would be something to see in the future as well. So coming to specific guideline-directed medical therapies in patients with CKD, beta blockers do not generally affect renal functions directly. If there is any worsening in renal function when you start beta blockers alone, it must be related to a low cardiac output state, which should be a concern. Otherwise, they are safe. This is safety, yeah? Efficacy, yes, there's moderate degree of evidence, because in some studies, beta blockers have been used in patients without exclusion without exclusion and low GFR categories. And from their safety profile, beta blockers can be used in patients with reduced ejection fraction, as we would have done to any individual without impairment in kidney function. The RAS inhibition, including ARNIs, they are recommended first-line therapies in heart failure with reduced ejection fraction. So some of the trials have included patients with CKD. 33%, or 1/3 of the paradigm heart failure patients have CKD, but all of them have a GFR above 30. So GFR less than 30 is not included. So if you have this is a recommendation from the European Society of Cardiology as well. If the GFR is above 30 to 60, you can use ARNIS as first line, as have used as any individual. If you have between 50 to 30, you can start low dose ACE inhibition and be cautious with up titration. And if eGFR is less than 50, either you don't start ACE inhibitor or cautious with it, and you can use hydroxyzine isosorbide combination. So the evidence for ARNIS is if GFR is above 30, also there is CKD, you can use it as first line. Beyond that, we don't have evidence of efficacy. For MRS, the fear is mainly of hyperkalemia. Of course, they can also induce renal dysfunction. Potassium levels up to 5.5 can be tolerated if closely monitored, minimizing dietary source of potassium, and caution is recommended if GFR is less than 30. It's not only caution, because there is also no strong evidence in this category of individuals. Better to avoid if GFR is less than 50 from lack of evidence as well as from safety issues. Potassium binders, particularly the newer ones, patiromer, sodium zirconium, have been tested in advanced CKD with MRS and have been demonstrated to increase safety of using MRS in this population. So if you have the luxury of getting patiromer and so on, I mean, I've checked the patiromer, it's a very expensive drug, and other potassium binders like Kixlate are cumbersome. They're not something that you would recommend for a very long-term use. So MRS have been excluded also in their major stages, rails, in fast heart failure. The GFR category that has been used is above 30, so less than 30 have been an exclusion. So we don't have evidence. SGLT2 inhibitors, yeah, we know there's an early decline in GFR, which is common and should not be a reason to discontinue therapy. There's always a question, how much should we tolerate in terms of decline in GFR? So it's not evidence-based, but people agree a 30%, more than 30% increment in serum creatinine, if it is persistent and particularly progressive, could be a reason to discontinue. If we don't have any other reason, if we have optimized, removed diuretics, other causes, that could be a reason. Evidence exists for GFR above 20. So for less than 20, we don't have evidence. So putting these things together, if GFR is above 60 and you have CKD, which is proteinuria or other markers of kidney damage, don't worry, start any treatment as you would have started in non-CKD population. If you have CKD earlier stage, which means G3, yeah, G3A and B, which is GFR between 30 and 60, start beta blocker, low dose. You can start ARNI or ACE inhibitor and full dose SGLT2 inhibitor, and with close follow-up to your potassium and serum creatinine. This is a recommendation. It's not evidence-based recommendation. This is a review, and the authors think if creatinine rises to less than 50% can be started, but many people would say 30%. Yeah. So while checking this would be a large chunk of group that you would like to optimize the medical therapy as you go along. So majority of patients, but for the other group of patients, for the end stage and for the CKD G4 between 50 and 30, beta blockers can be started. And between 50 and 30, like 20 and above, you can start full dose SGLT2 inhibitors. Are two important guideline-directed medical therapies that you can safely start. SGLT2 with caution, and you also monitor, but are generally safe. And you can add low dose ACE inhibitor after the up titration of the low-dose beta blocker, and then monitoring potassium and kidney function closely, usually in 2 weeks' time. For end-stage patients, beta blockers are the ones that you'd safely start. You might consider low-dose ACE inhibitors, individuals who are preparing for renal replacement therapy and so on, without too much of an up titration. This is like a practical thing that would guide. So you wouldn't add SGLT2 inhibitors, ARNIs in this group of patients, and MRS as well, because lack of evidence and safety concern. This would be the guideline dietary medical therapy. Heart failure management, if patients already on dialysis, there is lack of data here. And if there is any, mostly observational or single center, very small sized RCTs, poorly designed. So it's very difficult to get an evidence-based recommendation. The European Society of Cardiology guidelines give a class 2A recommendation for use of dialysis, renal replacement therapy in patients with CKD and refractory volume overload, which is straightforward thing, yeah. So somebody has refractory fluid overload, you're trying everything and nothing is working, and GFR, you would start dialysis in these patients. Yeah, that's a very straightforward sort of a recommendation. Otherwise, there aren't too much of guidelines. So there are observational studies for ACE inhibitors, ARBs, for heart failure in dialysis patients, with conflicting results, negative and positive as well. So it's very difficult to make a conclusion out of these small observational studies. And if you want to start, people prefer ARBs because ACE inhibitors are very dialysable and ARBs are less dialysable. We use this sometimes for blood pressure controlling patients on dialysis, and we prefer ARBs because they are not dialysable. There is no evidence-based recommendation on the use of ACE inhibitor in patients on dialysis for the purpose of heart failure. So beta blockers for heart failure in dialysis patients, one RCT, carvedilol based, there's significant benefit. There are also large observational studies with clear benefit. So beta blockers are safe and effective generally to be used in dialysis patients if you have heart failure with reduced ejection fraction. And in terms of dialysability, like for those beta blockers which are useful in heart failure, bisoprolol, metoprolol are easily dialysable, and carvedilol is not dialysable, so that can be used. But interestingly, there's a bisoprolol data which has been used in heart failure in dialysis patients, which still shows benefits. So dialysability might not be a big concern, but to be safe, carvedilol has clear benefits, been studied. Also, it's not a very large study. Carvedilol is something that you would tend to use. MRS in dialysis patients, there is no also good data. Low qualities, a small-sized RCT show there is some benefit with low risk of hyperkalemia. The hyperkalemia is not as we would have liked. Maybe it is safer than we thought, but the evidence is weak. So in a patient who you desperate, you have good potassium control, adherence to dialysis, diet, and so on, and then patients with heart failure, reduced ejection fraction on a beta blocker, that's what you can do. You might consider putting them on MRA with safety monitoring. Other guideline dietary medical therapies for dialysis patients, which is SGLT2 inhibitor, ARNIs, there is no evidence, and observational data in ARNIs with conflicting results. Which mode of dialysis to use in patients with heart failure is another issue. If you have PD, HD being a choice, in terms of evidence, there is also conflicting evidence, but in terms of the basic science, particularly in patients who have lower blood pressure, You might prefer to use peritoneal dialysis because peritoneal dialysis, intradialytic hypotension, intradialysis-related myocardial ischemias, and so on are lower with PD, but it's not a very strong evidence. With hemodialysis, if you're using a nocturnal hemodialysis is not just being at night, it's much more prolonged. You use it for a longer period of time, then the ultrafiltration rate is low. You can remove large amount of fluid within a short period of time. They have better blood pressure control, better symptom control, and also better outcomes. So if you have a nocturnal modality, then in patients with heart failure who are on dialysis, nocturnal prolonged HD is a good modality. So that being dialysis, the other big concern in patients with CKD is diuresis. GFR or albuminuria, proteinuria, low albumin start to be concerned. Am I going to get effective diuresis when this patient is requiring treatment for acute decompensated heart failure or fluid overload state? Yeah, that's another topic of interest by itself. I think this is from the European Society of Cardiology recommendations on optimization of diuresis or decongestive therapy. This is just for the general heart failure population, admitted patient, acute decompensated heart failure, how you would like to go about it. You start diuretics and how you would like to follow. I think you might have discussed this. I haven't attended this part, but the overall goal is to be able to discharge somebody in 3 to 4 days, yeah, after achieving optimal diuresis. And this is something I personally observe that we lack, yeah, and we have a safety concern. But the decongestive therapy, all the cardiologists say it has no mortality benefit. I can argue if you can keep a patient in perma-edema, don't give diuretics, start just optimize guideline therapy and see whether this patient dies or not, would definitely die. Yeah. So that's called mortality benefit, in my opinion. So I mean, over a long term, they're not randomized and so on. So diuretics include like RAS activation is there at the end of the day and so on. But nobody would randomize somebody in perma-edema with without diuretics. It's obvious, yeah? You cannot randomize somebody if they can have days from the 10th floor in this building and the 2nd floor in this building and see, yeah, there is no mortality. It's like that, yeah? So decongestive therapy is such a very important thing in the management of heart failure, particularly in acute decompensated heart failure. And when CKD comes, there is some risk of increased diuretic resistance. So I'm not going to discuss the details of diuretic resistance, but you have persistent congestion in a second day, started oral therapy, generally double of the oral therapy started, and you want to get at least 3 to 4 liters of urine in 24 hours, which is about 150 ml per hour, which is very important. Monitoring, and you're escalating therapy every 6 hourly, and you're not achieving that goal, what would you do? I mean, this is a mechanism of diuretic resistance that you would know. I'm just only adding the venous congestion component, increased intra-abdominal pressure, which can decrease renal perfusion, which decreases GFR and retention, in addition to the compensatory distal tubular hypertrophy that increases sodium absorption, and there are other mechanisms. So sequential nephron blockade, which most of you definitely have been practicing, adding thiazide and thiazide-like diuretics in a diuretic resistance patients is something beneficial. Increasing the dose of loop diuretics is there. When the discussion comes, so we have had lots of bedside-related discussion. What's the ceiling dose of furosemide that we can give? What's the ceiling dose of furosemide that you give as a bolus? 240. Okay. Any other ceiling dose? Yeah, diuretics have the so-called ceiling dose, not ceiling dose which means you can increase the dose, but there is no significant benefit above that, yeah? So that ceiling dose is shifted in patients with chronic heart failure, CKD, and so on. So you can increase the dose further, but you wouldn't have any benefit. Any ceiling dose that you use? 240, 120. 120 is just like for IV bolus without diluting, and 600 daily is a maximum dose. This is a pharmacologic book. I mean, you wouldn't get any guideline to the maximum daily dose, but if you refer to pharmacologic books, they would say 600 milligram dose of furosemide. It's a bit lowish, yeah? It's a bit lowish in clinical practice. There are studies, by the way, going to challenge 4 to 6 grams of furosemide a day in a diuretic-resistant patients, but we don't have the evidences yet. In practice, ceiling doses are 200, 240 bolus, yeah? Following one RCT continuous infusion versus bolus, there is no difference in terms of natriuresis and diuresis. People are discouraged using continuous infusion, but if you start the loading, the initial ceiling dose as initial, and you continue as a continuous dose, there is some improvement in diuresis. That study was comparing no loading dose, just continuous infusion, and then bolus dose alone. So you can give a bolus dose, you achieve diuresis, you can use continuous infusion. So the fear generally is ototoxicity. Ototoxicity can be ototoxicity. Irreversible ototoxicity has been reported, but generally it is reversible. And when you administer, if you administer it as the bolus dose, as an infusion itself, which means maximum infusion recommended 4 milligram per minute. If you're giving a 200 milligram bolus, give it over an hour, like 200, 240, an hour would be the way you can give it. So if you administer that way, you can achieve, and then you can maintain as continuous infusion or as man. So what's the maximum dose that can be given? Doses as high as 1 gram in advanced CKD, in severe AKI, even 2 gram has been used. But just further dose of increment in furosemide is unlikely to be beneficial, and sequential nephron blockage, which means tubular blockage. So the first thing to add would be a thiazide or thiazide-like diuretics. Most experience are with metolazone, but chlorthalidone, hydrochlorothiazide can be used, and those as high as 100 milligram of hydrochlorothiazide, monitoring electrolytes can be added. Then further adding MRS, distal blockade, and also proximal tubular agents like acetazolamide, and also finally SGLT2 inhibitors as a diuretic, yeah, as a diuretics can be seen. Tolvaptan, which is V2 receptor antagonist, can also be added. But generally, for our practical purposes, high ceiling dose of loop diuretics and either continuous infusion or intermittent bolus, add a thiazide or thiazide-like diuretics, escalate dose. You can consider adding an MRA and acetazolamide. With acetazolamide, I think you're aware of this adverse study, which was published recently in the New England Journal of Medicine. It's an interesting study which added acetazolamide in acute decompensated heart failure with volume overload. There's no hard endpoints that cardiologists would like, mortality and so on. It's just discharging patients soon, yeah? Discharging patients soon. So this is a successful decongestion within 3 days, and successful decongestion assessed at time of discharge was better with addition of acetazolamide compound. So we've started using some acetazolamide in some of patients. And the good thing is, there is a large proportion of CKD patients who've been included here, and actually the interquartile range for the GFR ranges between 29 and 51, median being 38, which is something very good. And we've also tried on the bedside adding acetazolamide with some success in some of the patients. We're trying to use acetazolamide as well, adding it to our decongestive therapy. So summarizing, like you have CKD, G5, carvedilol, other beta blockers being on top, and the rest of the therapy not having too much of evidence in this population. Thank you. Oh, yes. So, sorry. Dr. Adana reminded me about the case that we've raised. I think everybody would answer it because I'm such a good teacher, I have explained it. Thank you. So, in this particular patient who had heart failure with rejection fraction and CKD G4, yeah? So what would you do to this medical therapy that is already receiving? Changing in Alapril to ARNI, we wouldn't do this. We've said there is no evidence on ARNIs in patients with CKD G4 at all. Increasing the dose of ACE inhibitors, CKD G4 up titration can push. This patient has tolerance. The enalapril dose, so I would declining GFR. This is a rapid decline by definition and has tolerated it very well. I wouldn't either withdraw or increase the dose of ACE inhibitor because this is not a very acute rise, which we can attribute to ACE inhibitors. It's a gradual decline, would benefit for CKD and so on. There was one Swedish registry, which I haven't mentioned, large one as well, where they have tried withdrawing the ACE inhibitor in such type of population, and mortality was higher in patients where ACE inhibitors has been withdrawn. So adding MRA, not, yeah, CKD G4, no evidence, yeah, no evidence, yeah, safety concern being there. EPO not indicated at all, yeah, because this patient has hemoglobin of 11.6. That's not an indication to start EPO. IV iron therapy in patients with heart failure, although the type of iron that has been given in patients with heart failure is not the type of iron that we give, but like if you go to CKD population, there is no significant difference in the IV iron. So it's optimizing the IV iron. So this patient is already anemic, not only having functional iron deficiency, has TSAT, which is low, and we want to optimize that, and IV iron would be beneficial and should be started. So IV iron would be something that we would like to start, and we would not do none of the rest of the things. That's the answer.
Thank you, Dr. Addisu, for the very excellent presentation. I think we'll make the question and answer. Okay, we'll accept few questions. Okay, if you have few questions, we'll give. Do we have questions on the online community?
Thank you very much. I have two questions. The first one is on this case. If this patient wasn't on ACE inhibitor in case by case, would you dare to start ACE inhibitor? That's the first question. The second question is regarding MRAs. What we have is spironolactone most of the time, which is the cheapest, and usually as a standard dose we use 25 milligram. When you say lower dose, what's that in GFR 30 to 60? And for the cardiologist, do we give a dose more than 25 milligram in heart failure?
Okay. So would you start ACE inhibitors if this patient wasn't on ACE inhibitors at all? Yes. Yeah, and if this patient didn't have heart failure for like CKD progression and so on, you would like start to think, follow this patient. But this patient has heart failure and with a reduced ejection fraction, symptomatic, not doing so well, yeah? So we would start low dose ACE inhibitor. Would be cautious with up titration. That would be cool. That would be so. I mean, when you have a CKD population, where the ACE inhibitors would be having additional, particularly heart failure, is something that we would be. Regarding evidence, as I have said, that's something that we even with the dapagliflozin, he's been started some time ago. Yeah, I haven't added it as part of the question. If you start it earlier, GFR was better than 20. If the GFR is declining steadily, you don't have to withdraw the SGLT2 inhibitor, yeah, and you continue ACE inhibitor, the same thing. And regarding initiation, I wouldn't start SGLT2 inhibitor, but with the ACE inhibitor, I would start low dose and see. And the second, Low dose, like forced bile actor is 25, yeah? Particularly if you're having patients with CKD, G3 is quite a wide category, yeah? So it's 30 to 60. So somebody with 50s and 30s is completely different. So like individualization would be something that we use, but 25 would be something we would start in this population, definitely.
Thank you. I'll continue with Dr. Kefelegn.
Thank you, Dr. Addisu. As usual, you take cardiac part to nephrology. My question is: the patient who have CKD with reduced ejection fraction, ischemic, we like to do revascularization, but we're afraid for contrast, which patient or which stage of CKD not benefit for being by revascularization, or what's the precaution that we have to do? Thank you.
Okay. Yeah. Revascularization, if there is a clear cardiovascular benefit that you think revascularization would benefit this patient, be it in early acute presentation or any time that you would like, that would be the benefit aspect. Yeah, with the risk aspect, which is a contrast associated acute kidney injury. Yeah, it is not as a big and a bad problem as we generally think about. Yes, it is a real problem. It's not a myth, it's a reality that we have contrast associated acute kidney injury. But if there is a clear benefit with preventive strategies we try to do, you can do revascularization in any patient with CKD, but who's at high risk here. The lower GFR, the higher the risk, definitely. GFR less than 30 has higher risk, and that's a risk factor, definitely. But it doesn't mean that this patient should be excluded from revascularization therapy. So you do precautions, hydration, like avoiding metformin wouldn't reduce the incidence of AKI, but the metabolic acidosis, reducing diuretic dose or holding the diuretic dose, and giving low dose contrast if that's possible. Yeah, that's those sorts of preventive strategies you do. But this patient, if has mortality benefit, has like significant benefit from the intervention, you go for intervention with explanation. So we shouldn't exclude patients from getting a beneficial treatment of revascularization for fear of contrast-associated AKI. If there is marginal benefit, and if the evidence towards revascularization that you think is marginal, there is some risk, then you would have to explain to the individual patient. Some of the patients might progress to adults requiring state if they have already advanced CKD and so on. Otherwise, they shouldn't be excluded.
Thank you. For the sake of time, we will only allow some questions from the online community, if there are burning questions.
There are two questions that are raised. In those patients who are already on ARNI, ACE inhibitor, ARBs, or MRS, and patients with CKD, when the CKD progresses to stage 5 or they become dialysis dependent, shall we continue or withdraw this drug? The second question is there a benefit of starting low-dose dopamine in patients with acute decompensated heart failure and CKD with suboptimal diuresis?
Okay, dopamine, yeah, generally no benefit. Yeah, generally no benefit. There could be some detriment, some evidences, but not recommended. Regarding withdrawing ARNI, ACE inhibitor, MRS, if already started at higher GFR and individuals progress, this is not clearly addressed in any evidence, but we don't tend to withdraw unless there's a safety concern. Because the follow-up is initially when you start ACE, ARNIs, and MRS, you're following them 2 weeks, then closely monitoring for an acute insult. Yeah, if that has been a stable phase and they're tolerating and they're benefiting, then that should be okay. We don't withdraw these drugs unless there's a clear hyperkalemia, which is of a concern. But we must be clear. If I got somebody who's been started as CKD G4 advanced, all of them started at the same time, and patient comes, I would withdraw. But patient has been started a long time ago, has benefited from that, no hyperkalemia, no hypotension, and there isn't any evidence to indicate that withdrawing would benefit, and withdrawing and retaining would do more harm. So with lack of evidence, but these drugs being beneficial, we would still continue if there is no safety concern. The initial follow-up is the most important thing. Somebody has been following them. But with guideline-directed medical therapy, the problem is people are passionate to start everything at the same time, and then they're not following this individual, and you'd end up in not knowing what's happening to these individuals after 3-4 months because the acute follow-up was not there. Yeah.
Thank you very much, Dr. Addisu, for the excellent presentation. So now we will continue with our last presentation, which is about heart failure in patients with diabetes. I will call up on Dr. Getahun, who is a consultant internist and endocrinologist in Addis University. Hello, good afternoon. Now I'm going to present on heart failure and diabetes, the interrelation between the two. And I'll focus on the management of the diabetic part of heart failure, because I think you have been discussing about heart failure management thoroughly this morning. And because there is no significant difference in the management of heart failure in patients with diabetes and others, unless there is a specific situation, I'll mainly focus on the management of the diabetic part in heart failure. So me being the last presenter, I'll not be taking too much. I'll just focus on the main areas, and I'll let the floor for discussion. Like that. Okay. So this is going to be my agenda and introduction, diabetes and heart failure, pathophysiology of heart failure with a special emphasis on diabetic cardiomyopathy and the CV outcome studies. There are tons of studies. I'll mainly focus on the main ones. And finally, the most important drugs for heart failure, the SGLT inhibitors, and a conclusion. So as an introduction, type 2 diabetes is a complex disease with multiple comorbidities and with a dreadful complication if left untreated. And the main change in the treatment of diabetes now is it is shifted to early and intensive treatment rather than a scale-up treatment of diabetes. So by early and intensive treatment, we can prevent the complications, and the escalation treatment is being changed to de-escalation treatment nowadays. So the major mortality of diabetes comes from cardiovascular disease. So we can say that diabetes is part of a cardiovascular disease because like 2/3 of patients with diabetes eventually die of a cardiovascular disease. So what is special now is previously, the main concern of treating diabetes is to prevent acute complications, which may have an immediate disaster,
and the other is to prevent chronic microvascular complications and chronic macrovascular complications, which are predominantly atherosclerotic. But nowadays, because of the invention of the newer drugs and the FDA's warning on cardiovascular safety trials, now the impact of heart failure is just coming into the picture, and that's what I'm going to discuss today. So as a baseline, when we say diabetes is a rapidly growing pandemic worldwide, you can see in this slide that from 210 up to now, it has increased from 285 million to 537 million. And it's believed that it will reach 783 million by the year 2045. So this number is from the IDF data, 2021. And when the IDF data was released in 2019, this number was estimated as a projection to be attained in 2030. But we have reached to this number almost in 2 years. So this shows you how this pandemic is rapidly progressing. So I raise this point because diabetes is one of a significant cause of mortality and morbidity. And type 2 diabetes is a major independent risk factor for cardiovascular disease. It is a risk factor for cardiovascular disease, and it also affects the outcome of cardiovascular disease. So with the increase in the prevalence of diabetes, then we can expect that there will be an increase in the incidence and prevalence of heart failure as well. So Dr. Addisu has been saying that there is a close interrelation between cardiovascular disease, chronic kidney disease, and diabetes. And the shared pathophysiology and the shared prognosis is being now recognized, and drugs targeting and addressing these pathophysiologic mechanisms are being invented nowadays, like the SGLT2 inhibitors. Dysglycemia is highly prevalent in all patients with diabetes, and high blood sugar, even in the non-diabetic range, is strongly associated with an occurrence of heart failure, even in the non-diabetic range. And impaired glucose tolerance or impaired fasting glucose has been shown to have an adverse cardiovascular outcome. So heart failure is the first manifestation, the first cardiac manifestation of diabetes, but it is coming into attention recently. You know, the most common cardiovascular complication of diabetes is peripheral vascular disease, but the most common and the earliest manifestation, the earliest cardiac manifestation is congestive heart failure. So the relationship between diabetes and heart failure is being recognized now, and diabetes occurs across all the ranges of heart failure. Heart failure with preserved ejection fraction, reduced ejection fraction, or mildly reduced ejection fraction. And the most common being heart failure in the pure heart failure with preserved left ventricular ejection fraction. So by having diabetes, we'll go to stage A of heart failure. And then as it goes up, it will reach to the stage 4 heart failure. So, and by the time symptomatic heart failure issues, then the prognosis is too bad. So the occurrence of heart failure in a patient with diabetes strongly reduces survival. By the time a patient develops heart failure, then the mortality will go very high, as we are going to see it later. And prevention and management of failure and early diagnosis is associated with a better outcome in mortality. So observational studies, there are multiple studies which have shown that there is a 2 to 4 increase in the risk of heart failure in individuals with diabetes compared to those patients who have no diabetes. And the risk of heart failure is associated more in the younger adults and women. So the association between diabetes and heart failure is stronger in women and young adults than the older ones. The reason is not clearly understood, but this may be probably because of the hormonal profile of women, but its occurrence is much higher in women. And diabetes is also an important predictor of heart failure in those patients who have subclinical cardiac abnormalities, like left ventricular enlargement and dysfunction. And poor glycemic control is associated with greater risk of development of heart failure. Even an increase in hemoglobin of A1C of 1% is associated with an 8-fold increase, an 8% increase in the incidence of heart failure. So this is to show you that patients with diabetes are at increased risk of developing heart failure, and diabetes confers a 60 to 80% greater probability of all-cause mortality in those patients who have established heart failure. And these are the predictors of incident DAME in those patients who have diabetes. These are the factors which should be scrutinized or which should be intervened before the development of heart failure. And this include elevated body mass index, especially obesity is strongly associated with cardiomyopathy, and history of smoking, elevated glucose or hemoglobin A1C, elevated systolic blood pressure, long duration of diabetes, defined long duration of diabetes, and diuretic therapy, and New York heart classification. These are predictors of diabetes in those patients who have heart failure. So but the relation between heart failure and diabetes is bidirectional. So the presence of heart failure increases the incidence of diabetes, and the presence of diabetes increases the incidence of heart failure. So there is a bidirectional relation between the two. So metabolic impairment and intrinsic pathologies in heart failure, there are both hemodynamic and volume abnormalities which are associated with the increased incidence of diabetes. There are several neurohormonal changes which occur in patients with heart failure that lead to the occurrence of diabetes. And there are several studies in the heart failure population which have showed an increased incidence of heart failure. And this is just to mention some of them. You can see that there are so many studies of patients with heart failure which have shown an increased incidence of diabetes. So diabetes not only increases the incidence of heart failure, but also it affects outcome. Like it increases days and hospitalization significantly. And this is an independent predictor of days. It increases hospitalization and readmission for heart failure. And it's also associated with an impaired quality of life and readmission. So this is to show you that by the time heart failure occurs, survival of patients with diabetes significantly decreases, as you can see from this curve. This is in those patients who are free of heart failure, and this is in those patients who have incident heart failure. So then the curve goes down. That means there is a significant reduction in survival. So diabetes and heart failure, this is a bidirectional relation between the two. As I've said it, when you have heart failure, you are at risk of developing diabetes. And when you have diabetes, you are at risk of developing heart failure. And these are the reasons for this. If you want to see, diabetes causes heart failure because it's known. It has two pathways because it increases risk factors for development of heart failure, both with the association of the traditional risk factors and with the incidence of other hemodynamic metabolic abnormalities like oxidative stress, like mitochondrial dysfunction, and the shift of fuel from glucose to free fatty acids. Because you have severe insulin deficiency, patients will shift to the use of free fatty acids, which are less efficient sources of energy for the myocardium. And this is associated with a dysfunction. And also, when insulin is deficient, there are two things happening. One, there will be a deficient function of the lipoprotein lipase, which is responsible for the clearance of triglycerides. And the other, there will be unopposed lipolysis. And the end result of it will be an increased triglyceride in the serum, which is associated with fat deposition all over, including the myocardium, especially in the epicardial area, which is associated with cardiac dysfunction. And again, the raising triglycerides also is associated with hyperglycemia at the same time because it inhibits the postprandial glucose clearance. And postprandial glucose clearance is mainly by the consumption of glucose plus by the glycogen synthesis. So in the absence of, in the presence of free fatty acids, both mechanisms are impaired. So again, there is hyperglycemia. So there will be a cascade which is occurring. And again, I will show you. There is also, when the body uses free fatty acids as a source of energy, there are several byproducts which are strongly associated with inflammation and fibrosis. And this is the relation between diabetes and heart failure. And the other is heart failure also causes diabetes. And there are several mechanisms for this. One is unfavorable metabolic profile. That is, there will be stimulation of the neurohormonal mechanisms, including sympathetic activity, angiotensinogen, aldosterone, and nitro. There's also reduced functional status because there will be decreased mobility, and that will be associated with impaired glucose utilization, and there will be inflammation and oxidation as well. And the other is associated with treatment of heart failure. Most of the drugs which are used for the treatment of heart failure may adversely affect the blood glucose level. And mainly diuretics and beta blockers are associated with an increase in the blood glucose level, especially from the beta blockers, the older generation. The non-selective ones are strongly associated with hyperglycemia, and the diuretics was loop diuretics, Lasix and hydrochlorothiazide are associated with an increase in blood glucose. And the others, the mineralocorticoids also, and some of the treatment for heart failure, like AC inhibitors, AC ARB blockers, and SGLT2 inhibitors are also, they are associated with a better and a favorable outcome. So the main thing is mainly from the beta blockers and the diuretics. So these are the reasons for impaired. Generally, heart failure is an insulin-resistant state. So when you come to the pathophysiology of heart failure in diabetes, both the old, that's the atherosclerotic pathway, and the non-atherosclerotic pathway contribute equally to the development of heart failure. Especially nowadays, the non-atherosclerotic pathway leading to what's called diabetes-induced cardiomyopathy, or cardiomyopathy in people with diabetes is increasing in frequency. So the difference between this is, you will see that this is the main pathophysiologic mechanism. When you have type 2 diabetes, you have hyperinsulinemia, insulin resistance, and a delayed insulin clearance. And in this situation, when you have insulin resistance, it's the metabolic effect which is impaired, otherwise the RAC pathway is not inhibited. And the RAC pathway of insulin is associated with inflammation. So that is not inhibited, or that is not, that doesn't develop resistance. So there is a hyperinsulin state with insulin resistance, a delayed insulin clearance, and activated RAC pathway that leads to extensive inflammation, fibrosis, and myocardial injury. So there are the two pathways. You can see that this is inflammation. Dyslipidemia, you know that diabetic dyslipidemia is highly atherogenic with a high level of low density LDL molecules, which are highly atherogenic and which are resistant to clearance by the LDL receptor. There is also endothelial dysfunction, which is both from hyperglycemia and from hypoglycemia. And again here, glycemic variability also plays a role in endothelial dysfunction. And this leads to coronary artery disease with ischemic cardiomyopathy leading to heart failure. And the other one is the inflammatory pathway. There are several things that are happening, like autonomic dysfunction from diabetes with a variable in heart rate. There will be impaired calcium handling, and there is a fatty acid utilization leading to advanced glycogen end product production. And there will be activation of RAS, severely activated, which is associated again with inflammation. And there will be LV hypertrophy. This is a typical manifestation of diabetic cardiomyopathy, LV hypertrophy. And diabetic cardiomyopathy was actually started, the notion was started like 1970s, where patients dying of from diabetes was found to have heart failure, but no coronary artery disease. So diabetic cardiomyopathy is defined as LV dysfunction in the absence of all risk factors like hypertension, coronary artery disease, dyslipidemia, and valvular heart disease. All things excluded, there is only LV hypertrophy and dysfunction, and that leads to heart failure. And this is called diabetic cardiomyopathy, or cardiomyopathy in people living with diabetes. This is typically also occurs in patients who have obesity. And this is to stress the role of free fatty acids that I said, because the body uses a less efficient utilization, then there will be cascades of inflammation that leads to fibrosis. So these are the things that are happening. There will be a pathophysiological mechanism, intermediate mechanism, and that leads into subclinical abnormalities. Most patients with diabetes have subclinical cardiac abnormalities before they manifest the end stage, that is heart failure with preserved or reduced ejection fraction. So this is a pathophysiology. Now, the diagnosis and clinical staging heart failure, I will not go into the details, but what is peculiar in diabetes with regard to the diagnosis of heart failure is it's very difficult. And I've said it, diagnosing and treating heart failure in the earlier stages has a better outcome. So that's the main purpose of the discussion. And now screening mechanisms are coming into the picture. The earlier you treat heart failure, the favorable will be the prognosis. So the problem is the typical symptoms of heart failure are not evident in the earlier phase of stage heart failure, because shortness of breath, breathlessness, and all the others may simulate other morbidities which occur in diabetes, and they are less specific to that. And imagings will not reveal this abnormality. So there is always a difficulty in diagnosing heart failure in the earliest stage in diabetes. And most of it, especially that heart failure with preserved ejection fraction, is misdiagnosed or is not diagnosed early. That has been shown in several studies. So these are the stage A, stage B, stage C, and D. So what is difficult and what is important is to diagnose heart failure in stage A and stage B. Because by the time the patient has diabetes, he's automatically in stage A. So detecting heart failure at this stage has a better outcome and better prognosis. So here comes the role of the biochemical diagnosis of heart failure. And this should be done annually in all patients with diabetes, so that you will have a prediction for the occurrence of heart failure in the coming 5 years. Otherwise, stage C and stage D have no problems. That's a clear one. So this is a biomarker-based risk prediction of heart failure in diabetes. So these are the biomarkers which are used. That is troponin, pro-BNP, high-sensitivity C-reactive protein, and ECG. So giving 1 point for all scores, then the more scores the patient has, both in overt diabetes and impaired fasting glucose, there will be higher prediction for the occurrence of heart failure in the coming 5 years. So this is now being utilized in the diagnosis of heart failure in patients with diabetes. So these are the risk factors which we have said for the development of heart failure, both traditional and new, that are the novel factors are incriminated. So the ACC guideline has actually included other risk enhancers which are independently related with the occurrence of heart failure. And these include long duration of diabetes that is defined by greater than 10 years in type 1 and greater than 20 years in type 1 and type 2. Type 2 greater than 10 years and type 1 greater than 20 years. And albuminuria, reduced eGFR, retinopathy, neuropathy, and reduced ankle brachial index are associated, are incriminated as risk enhancers in diabetes. And this is important because we should risk stratify patients with diabetes. And as you know, by the time the patient has diabetes of enough duration, he goes directly into moderate risk. And the presence of and the duration when it's greater than 10 is high risk, and the presence of end organ damage or established atherosclerotic cardiovascular disease will make it a very high risk. And this risk stratification, you know, is very important in the treatment. So having said this, I will go to the management. The management of heart failure, the management of diabetes in heart failure, as I've said it at the beginning, because the management of heart failure in patients with diabetes is almost similar to the non-diabetics, and that has been discussed. And always when there is diabetes and heart failure, because heart failure is more serious, the priority is given for heart failure treatment. And we shouldn't worry about the side effect of drugs and ACE. Always heart failure treatment should be given the priority. So glycemic goals always, in diabetes, glycemic goal is individualized. And in patients with heart failure, the best glycemic target is not yet set. It just follows a U-curve. And as you know, the reduction of hemoglobin A1C to the lowest possible was not associated as expected to reduce macrovascular risk factors, as it has been evidenced in the old landmark studies, the DCCT, UKPDS, VIDT, ACCORD, and ADVANCE. And in fact, a lower hemoglobin A1C of 6 was associated with an increased occurrence of cardiovascular diseases, which was seen in the ACCORD study. So the optimal targets for patients should be individualized. And most of the patients, in most of the cases, a hemoglobin A1C of 7 to 8 will be the best level for patients with heart failure, but this should be individualized. And these are, what are the parameters? That is life expectancy, duration of diabetes, severity of heart failure, and occurrence of other comorbid conditions will set the target to a higher or a lower level. So the main thing here is to avoid hypoglycemia, because hypoglycemia is detrimental, especially when the myocardium is affected. So hypoglycemia should be avoided. So if the patient's life expectancy is long and there are no serious comorbidities, you may go down. And if his life expectancy is short, duration of diabetes is very long, severity of heart failure, and you depending on that, you may the level may fluctuate from one to the other. And the other important thing in the choice of anti-hyperglycemic treatments is their impact on heart failure. Because some of the drugs used for the treatment of diabetes are associated with an increased incidence of heart failure that has been evidenced previously before the FDA's requirement of a cardiovascular safety trial that you know. Because two of the drugs, that's the TZDs, rosiglitazone and pioglitazone were associated with an increased incidence of heart failure in the recurrent and the proactive studies which were done. They were good drugs for diabetes, wonderful drugs, but they were associated with an increased hospitalization for heart failure. And again, the DPP-4 inhibitor saxagliptin was also associated with an increased admission for heart failure. So this risk was serious, and a legislation was, and the FDA in 2008 has actually requested a cardiovascular safety study before any molecule for the treatment of diabetes is approved. And that is the most important landmark. And had it not been for that law, we didn't have discussed all these details today. So when the cardiovascular safety study was conducted for drugs for hyperglycemia, then the benefits, the cardiovascular benefits all came. And some of the drugs are now taken out from diabetes to the treatment of drugs, the disease related to the cardiovascular system. So this is the milestones here. These are especially, the previous treatment was mainly focusing on glycemic control, and there are no emphasis on the occurrence of cardiovascular diseases. But later, because of the studies that were released in 2008, the FDA released guidelines for cardiovascular safety study. And then all the drugs with cardiovascular and renal benefits emerge. And this is generally to see the effect of the previous drugs. For example, sulfonylureas, especially the old generation sulfonylureas, are associated with worsening heart failure. The TZDs are associated with heart failure worsening. From the DPP-4 inhibitors, saxagliptin is associated with an increased incidence of heart failure, but the rest are not associated with that, including linagliptin. The other studies have shown a safety, but for this fear, these drugs are not indicated in advanced heart failure in the treatment of hyperglycemia. Insulin, again, is associated with fluid retention, but later studies show that its effect is neutral. And GLP-1 receptor agonists, they are again neutral to heart failure, but the SGLT inhibitors have a significant benefit on reduction of the occurrence and hospitalization for heart failure. So after the 2008 declaration, so many studies were done. You can see that there are several studies done on several molecules, especially the GLP-1 receptor agonists, the DPP-4 inhibitors, SGLT inhibitors, and now again, a combined GLP-1 and GIP receptor agonists. There are studies being conducted. So to see, I will not go into the details, but to see some of the studies for the new agents, this is the DPP-4 inhibitors. There are several drugs, that's alogliptin, saxagliptin, sitagliptin, vildagliptin, and linagliptin. All these are DPP-4 inhibitors. And the major outcome from this is all of them are cardiovascular neutral, except saxagliptin, which has shown an increased incidence of heart failure by 27%. That is in the SAVIOR-TIN study. Otherwise, the other studies have shown that it is cardiovascular neutral, like the TACOS, and the Carolina and Caramilla studies all have shown, especially with linagliptin, where the patient population was with advanced heart failure, with advanced cardiovascular disease, the incidence of heart failure was not increased. And this is the impact, all of them, especially this one is a heart failure study, and most of them have proven safety. That's linagliptin, sitagliptin, and saxagliptin has proven safety, but the impact of alogliptin is unknown. And the other is the GLP-1 receptor agonists. They are all the list of GLP-1 agonists, and their impact on the outcome of heart failure is neutral. They are beneficial on atherosclerotic cardiovascular disease, but their impact on the occurrence of heart failure is neutral. And some of them, not all, have shown cardiovascular safety, like liraglutide and semaglutide. And these are the studies which were done: the ELEXA, the LEADER, SUSTAIN-6, Harmony, Rewind, and Pioneer on all the possible GLP-1 receptor agonists, but their impact on heart failure, this is not included here. Some of them have reduced cardiovascular days and better renal outcomes, but the impact on heart failure is neutral. And these are the SGLT inhibitors. This is the range. They have been started from patients with diabetes, and then with diabetes heart failure, and then in patients without diabetes. And across the board, they have shown a significant benefit on reduction of heart failure hospitalizations. Both canagliflozin, dapagliflozin, empagliflozin, and etrogliflozin have shown significant benefit in the CANVAS, DICLIMI, EMPAREG, and the VERTIS trials. So this is the reduction in the rates. You see the empiric, there is a 37% reduction, 33% reduction, 27% reduction, and the 23% reduction with etroglyphosine from the VERTIS trials. So this, and again, there are other newer agents. For the sake of time, I'll go fast on that. There are sotagliflozin, that's a combined SGLT1 and SGLT2 inhibitor. This is a drug which was being tried for the treatment of type 1 diabetes, and which was where there was an increased rate of decay. But this drug was also assessed for heart failure, and it has shown a significant benefit with 23% reduction in hospitalization for heart failure in 2 studies. That's the Soleast worsening heart failure study, and the other is the SCORED study. Both of them were studied in patients with type 2 diabetes, and both studies have shown a significant reduction in the rate of heart failure and hospitalization. And that was early as the other SGLT inhibitors. So this, so from these all studies, the SGLT inhibitors have been found to have a beneficial effect on the reduction of hospitalization of heart failure and the occurrence of heart failure. And so they are becoming now drugs for the treatment of heart failure as well. So despite knowing the benefits and the cardiovascular outcomes of all these anti-hyperglycemic drugs, the rate of utilization of these drugs is very minimal. Even in the developed world, only 1 in 4 patients receive optimal management addressing cardiovascular outcome and heart failure outcome. And this is even more in our situation, but we know that's very difficult to have it here for the very expensive costs that they have. So this is about the management of hyperglycemia and diabetes with specific drug choice. So these all studies, this is heart failure management in diabetes. As I've said, you have discussed it. So it just follows all the recommendations for other heart failure problems for non-diabetics. So what is the result from these all studies have actually brought a paradigm shift in the choice of drugs for the treatment of hyperglycemia, especially in the presence of established cardiovascular disease, renal disease, and heart failure. So these are the algorithms. Now, previously, metformin was the first drug, and now even before metformin drugs are coming, in those patients who have established cardiovascular disease, heart failure, and even in those patients who have multiple risk factors. But generally, after metformin, the choice should be changing. 1, if the patient's problem is predominantly atherosclerotic cardiovascular disease, then we should choose a GLP-1 receptor agonist with proven efficacy. That is liraglutide mainly, and then the others, semaglutide also. And if heart failure or CKD is predominant, then those drugs which have been proven to have benefits with reduction to heart failure and worsening of renal function should be chosen. If there is no atherosclerotic cardiovascular disease or CKD, then you can go to any drug depending on the other parameters that the patient has. And this is the same. So this is all I have. In summary, type 2 diabetes is a heterogeneous and progressive disorder that represents a series of metabolic conditions, and it is a major independent risk factor for diabetes. And now secular trends in the prevalence of diabetes and heart failure forecast there is a significantly growing burden. And recent clinical trials demonstrated the potential benefits of therapies in modulating other cardiovascular risks. And always, we should focus on multidisciplinary interventions to improve clinical outcomes in patients, especially with heart failure and diabetes. And that's all. Thank you. If you have questions. I think it must be very clear.
If you have questions, till you think of questions, do we have questions in line?
Thank you for your presentation. And I don't know whether there is like SGLT2 inhibitor, which is applauded by 3 disciplines like in cardiology, endocrinology, and nephrology. And now we all know the benefit. And as an Ethiopian, my problem to prescribe is the big issue is the cost. And when you sided with the people, usually you feel how it is painful, okay? You know, the benefit, and particularly when they come with multiple complication and also dual or 3 diseases. So I see there is a lot of expertise here in all fields. And what is your possible strategy to convince and anything to increase the uptake of this drug? That's my question.
I think this is a very difficult question, but I don't know. Any other question? Yeah, it's very expensive, we know. Even we cannot afford to buy it, and it's becoming very expensive. And those patients who have started previously are now becoming unable to buy it because the cost is increasing significantly. So, but now the good part is I think it's being incorporated into the health insurance system. I think they are just working on that. So we can get, I think Porsega is given as in the health insurance. They are just giving it to 1 month, for 1 month's supply. So that will be a good thing to have. And the other is, I think knowledge is also, for example, I may not need to say this here, but fortunately, I'm actually the president of the Ethiopian Diabetes Association. And after several communications, we were able to bring canagliflozin for free. And there are significant amount of canagliflozin that was distributed to hospitals, but none of them were using it. Yeah, this is a very expensive drug. And in millions, the cost is in millions. So in any hospital you mentioned, there is canagliflozin, but the rate of so we can't proceed with asking the second shipment because it's going to expire. So I think it's good even to know is also, even in Awasa, there is canagliflozin, by the way. And that's given for free. And that's what we can do actually. And by the way, we are also, they were very positive to supply us much more, including empagliflozin actually. We have requested empagliflozin and I'm sure they're going to send it. And they send it in tons actually, but unless we use it, it will expire. And we can't ask the second shipment. So in the Melkie no actually, please try to use it. ሁሉም አለ ጳውሎስ አለ ሴንት ፒተር አለ ጥቁር አንበሳ አለ ጥቁር አንበሳ እንኳን የተጠቀምንበት ነው እኛም ስላለን ያ ፎርስ ስለምናደርግ አዋሳ ጅማ መቀሌ ሁሉም ቦታ አለ and I think please use the drugs with a proper indication. Any other question if you have? I think let's stop here if you don't have.
If we don't have further questions, we'd like to thank Dr. Getahun for the excellent presentation. And thank you all for coming and for your time.